I've been counting people as they have come on, and I think we're above a quorum. So let me take an official roll call, and then we can get going. Dr. Goodman?
I'm here.
Okay. Dr. Williams?
Present.
Dr. Liberzon? Dr. Harper?
Present.
Dr. Wakefield?
Present.
Dr. Trevino?
Present.
Dr. Thompson?
Present.
Dr. Martin?
Present.
Dr. Podolwitz?
Present.
Dr. Chassé?
Present.
Dr. Nemiroff?
He won't be here.
Okay. Dr. Strakowski?
Here.
Dr. Tan? Dr. Robert? Dr. Wagner?
Here.
Okay. Dr. Vo?
I'm here.
Dr. Suarez? I haven't seen him. Dr. Newland? Dr. Plitzka?
Here.
Dr. Blader?
Present.
Dr. Escamilla? Didn't hear him. Mr. Petrarca? Dr. Matthews? I saw Jeffrey. Dr.
Here.
Matthews?
Here.
Okay. Brittany Nichols?
Here.
Dr. Taminga? Dr. Ibrahim?
Here.
Sonia Gaines?
Here.
Mike Maples? Okay, I don't have Mike yet. Dr. Silverman? Miss Wesley?
Present.
And Andy Keller. I saw Shannon. I think Shannon is sitting in, but she can't vote.
That's correct. I'm here for Andy.
Okay, great. Dr. Martinez?
Here.
Okay. Danette Castle?
Here.
Okay, I'm here. And Dr. Borges? Okay, let me count real quick.
Dr. Lakey, Dr. Taminga, and Dr. Liberzon have joined.
Okay,
Dr. Newland as well.
all right.
That will
Dr.
make
Liberzon,
24.
you're here? Liberzon?
Right here.
Okay, good. Thanks.
Taminga too.
Taminga, okay.
I'm here too, Dr. Lakey. Sorry, this is Liz Newland.
Okay. All right. Well, we definitely have quorum. So we'll go out. I will let somebody else count them, but I had 22 before, and we've added about 4 additional ones. So it's 25. Nicholas just told me that we have 25. So we're definitely above quorum. Why don't we go ahead and get started? Dr. Silverman is here too. So let me add her. I know you guys are incredibly busy right now with everything that's going on. And so thank you for your time as we try to keep things moving forward with the consortium. We are going to do things a little bit different in that we're going to do 3 hours straight and go through the business. So it's a little bit shorter, but we'll just go straight through the business of the day. We're going to touch on the implementation of the various items. We'll do that pretty quick. I think we're going to spend a little bit of time going on the update of the cost, and then spend some time thinking through budget and where we are related to this year's budget and next year's budget. So why don't we do the first item of business, which is the minutes from the last meeting. If people will take a look at the minutes.
Move to approve.
Second.
I heard a motion and second. Any further discussion? Hearing none. All in favor, we'll do this verbally. All in favor of approving the minutes, signify by saying aye.
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 Any opposed, nay? Okay. I'm going to turn off my video right now. I'm getting some static when I have my video on. And so I'll see if I can do it like this for a little bit. So we've completed the minutes. Let's, Luanne, anything before we jump into everything, all the rest of the agenda?
No, I think the next section of the agenda, we're going to hear from various folks about updates on the initiatives that are going on. And first up, we've got Dr. Molly Lopez and Dr. Tracy Levins from the University of Texas, Austin.
All right, I'll jump in. So we just wanted to provide a little update on where we are on evaluation. So just as a reminder, our role is really to focus on the internal evaluation. So really supporting you all in understanding kind of what's happening, what accomplishments are occurring, and how we might define those data points. So we've been working on developing an evaluation plan. We've got a draft of that plan in and have had the chance to have some conversations about that. And we look forward to continuing conversations with folks about that. We've been using that opportunity to help define some of the data collection and reporting procedures, really with the goal of ensuring that data is standardized across the HRIs as it gets gathered. So we all kind of know when we're talking about a particular metric that we all sort of have the same understanding of what's going into that. Also wanted to remind you all that one of the things that we can do is help provide staffing really to assist with gathering the data if that's needed, if it's not something that can show in the COSH or other sort of data systems, we can help with gathering that, such as if we were to do surveys or stakeholder interviews, those kinds of evaluation activities. And then we can help with analyzing that data, visualizing it, kind of sharing it with you all in a way that's useful and helpful. So in that evaluation plan, the primary things that we've been doing has been creating draft data definitions for the LBB measures. We have tried to kind of take those broad measures and think about all the different ways that people might want to define that and create some standardized ways. And then we're bringing those definitions to you all to get feedback and input on it. And that's just starting. I know that it's kind of paralleling some existing processes. So we want to kind of figure out how to feed into that and be helpful, but not slow down the work that's happening in some of the work groups. We've also been trying to identify additional evaluation questions, some that we've heard raised in this forum, things that you guys are interested in understanding, and other ways that we might look at data that goes beyond those LBB measures. One of the things that we've done as a part of that evaluation plan, and I think Nagla is going to pull it up on the screen, is create a couple of logic models. It's always a nice way to kind of start as you're laying out evaluation to try and lay out what some of the logic is behind the work that you're doing. So this is an example of the CPAN one, really trying to lay out what some of the assumptions are behind CPAN, some of the inputs that the group is putting together. And then of course, as we move forward in the logic model, what are the short-term things we want to make sure are being accomplished and that we can document are happening? Things like, are we providing the consultation? Are we engaging the pediatricians and other prescribers in CPAN? And then of course, importantly, what are some of the long-term outcomes that we're hoping to see as a part of that? And how do we measure those? So I don't want to go, you guys will have those, you can look at them and share feedback. I know this isn't really a great way to kind of read a whole bunch of words on the screen. We really have just created these for CPAN and TChat, as those are sort of the more complex initiatives, but we've sort of built a basic logic model into the other ones as well. One of the things we did want to put to the group today, if possible, is around kind of a gap that we saw as we were trying to define some data definitions, and that was around how we want to define children and adolescents in our data definitions. This is probably important in all of them, but it's particularly important in CPWE as we try to define the number of patients that are seen that are children and adolescents versus adults. And as you all know, we could break that up by Medicaid definitions. We could break it up to 18 or any sort of combination thereof. But as far as I can tell, that hadn't yet been defined. And so if it has, I would love to get input on that from folks.
I mean, typically, if we think, this is Karen Wagner, if we think about children, adolescents, we tend to make definitions be 18 and above. Yet that would be in the young adults, but children and adolescents is usually 17 and below. We have a lot of clinics to find, and also you have the issue of parental consent. When someone's 18, they can do things without parental consent.
I would say also, I mean, obviously that's a definition that we all use very frequently. One of the consideration, and maybe the exact right one to use here, one of the considerations is that especially for CP, we are doing a first episode psychosis integrative program. And so do we want to count, or is it going to be counted against us, or how do we additionally account for those 18, 19-year-olds or 20-year-olds? And then in the research studies, we're also looking at up to 20, I believe, in both of the studies, Dr. Wagner. Is that right for the trauma as well?
That's correct.
Yes, it is.
Okay.
We're calling them young adults, but yeah.
So we may want to have 3 different clarifications of children, adolescents, and young adults, but quantify all 3 of those.
Mm-hmm.
So the
Transitional age.
the adolescent medicine people extended further on. If you go to pediatrician or adolescent medicine, because a lot of my first, second year students are still seen by their pediatrician or adolescent medicine and not get transferred to the internal medicines or family docs. So I don't know how we fall with that one. I would think that either we create a separate category or just expand it a little bit more so those people can be counted and we don't shoot ourselves in the foot.
Why don't we count them as transitional age? So you have a pretty standard definition, children, adolescents, and transitional age.
That's good.
And so I'm hearing for transitional age up to 20, or would we like to go beyond that? I know the early psychosis certainly goes well beyond that.
I mean, I would say just that we could use the as much adhere to the definitions that other people use, if we can, for children and adolescents and transitional age youth. And then if they're above that, but they're caught, they are being seen in that program, then we can just quantify them as adults.
So, I mean, my understanding of transitional age youth is it does get defined in different ways. So if we wanted to carry them up through 20, that aligns with Medicaid's definition. If we wanted to include them up through 24, that's a pretty common definition as well.
I think one of the issues is like in CPW, like Alan Allen's program, a significant number of adults are being seen. I mean, even middle-aged adults. Is that correct, Alan?
That's correct.
So I would suggest we just have 3 age groups, 17 and under, 18 to 21, 22 and above. And the vast majority of the patients are going to be in the first group. And we don't worry about whether they're transitional. That's just very concrete, logical way to do it that'll be consistent across all HRIs. And as opposed to trying to have different definitions that can vary, is a 19-year-old developmentally disabled person still a child? Mentally, yes, but for our purposes, they would go in the transitional group.
Yeah, because some of the schools will consider some of the IDD kids who are still in high school, and they may be, 20 years old, but they're still in high school.
Right.
I think the age group drop down should just have 3 levels. We have the age as a continuous variable, and then the age group will have these 3 groups, and that should make our analysis relatively straightforward.
Dr. Pliska, do you think there's value in separating children and adolescents to talk about how early we intervened or not?
If you wanted, a good point, if we wanted to have, we could even have preschool, we could have 5 and under, 6 to 12, and 13 to 17. I wouldn't object to that in that drop down. Yeah, that would allow a certain degree of make and these are all easy to calculate because they're calculated on whatever age is in the database. So there's no effort to doing it that way.
I would agree that level of detail will help us focus future efforts if it doesn't cause additional distress to the system to do that.
Yeah, I'd agree with that.
Okay, great, super helpful. Okay, I've got our age categories is 0 to 5, 6 to 12, 13 to 17, 18 to 20, and then adult.
21.
I apologize, but between 17 and 18, they're still alive and with us. So we cannot stop 1 and 17 and start the next group.
You're not, this is just for tracking them in the database. You know?
No, but even in the database, there will be 17. Oh, so they should be meeting. So everybody who is 17,
At the moment of the analysis, they'll go into one of these categories. Not, you know, granted they'll be starting at age, if they start at age 16, you know, eventually they'll that when you do it a database, the category they're in will shift depending on what point in time you're looking at the data.
So Steve, you had mentioned 21. So usually like within Medicaid, it's going to stop up to age 21. Would you want them through age 21 in that category?
I don't have strong feelings on it. If it's more meaningful to say 21 is kind of, most people are, that's considered you're no longer a young adult once you're a transitional adult once you're 22. So just going by the common usage. But if 20 has other legal reasons we should use it, that's fine too. What do you think? I'll go with your judgment, Molly. What you think?
Okay. Hearing no other concerns, I think that sounds good. Okay. Thank you guys for informing that. That's really helpful.
No problem.
I think that was it for me, Dr. Lakey.
Okay. I don't think we need a formal vote. It sounds like there was consensus there. And so Molly, you have what you need, right, related to those age breakdowns. Okay. So why don't we then transition to the external evaluation. Luanne or Nagla, you want to tee this up?
Nagla, do you want to just provide an update?
Sure. I think at the last meeting, we talked about trying to get the RFP out. It got delayed a little bit, but it's going out this week. And we're trying to schedule a meeting maybe sometime next week. It's a pre-proposal conference. The thought is to have this open until September 1st. So these are the timelines for the evaluation. And then bring on board an entity sometime between September and October.
So presumably when all the applications come in, then the evaluation work group will convene to start the review process.
Right. So we're going to conduct the review process internally through UT System. We may ask for folks to provide some input related to just their technical expertise. And then we will go ahead and identify the candidate after that.
Even better.
So Nagla, Luanne, I had a chance to read this, of course, and to go over it. For positions like this, it's almost universal, really, to give at least a little bit of an honorarium because the people spend their time and they're not a part of the project. Is there some reason that the UT system cannot give an honorarium?
Are you talking about, Dr. Dominga, I think you're talking about the peer review process.
I'm sorry. Yes, I am. I'm sorry.
It's all right. We're talking about the external evaluation, which will be the contract. The amount that we've identified was, in the LBB report is about 750,000.
I'm embarrassed. I'm sorry.
It's okay. It's all right.
Right. Monday. Any questions?
All right.
As soon as we get the RFP out, we're going to try to send a message out to all institutions in Texas that would meet those qualifications. So.
And I think we can copy everyone here on the executive committee too, right? To make sure that you have visibility of it going out. And then you can send it to folks you think would be good at providing this service. Okay. All right, let's move on then to the workforce expansion. Steve, you want to lead this?
Yeah, certainly. I wonder if we could put up the memo from HHSC that I sent out as part of the CPW minutes from our last workforce meeting, because I think it would be most informative to walk people through where we are.
Hey, let me see if I can find that in my email. Hang on.
I can send it to you real quick if you can't find it. Or if you give me control, I could show it from here.
It's the one that was sent to all of the
Sent to everybody. It's not the actual minutes, but the document. I think it has HHSC in the title.
Okay.
And Dr. Plitzka, as long as no one else is sharing, you can share.
Sorry?
As long as no one else is sharing, you can share a document.
Ah, there we go. First, let me find. Now I have to find it.
I was hoping you would, because I can't right now.
Okay,
But
hang on just a second. Give me a moment here.
I can search while you're searching.
No, that's okay. I got it.
Okay. Too many emails.
Let's see, am I? Hold on, let me get it where it's. I found it. I just need to get it where I know I'm sharing it. Okay, there we are. It says Senate Bill 11, Texas project. That's the one. Everybody sees it?
Yes.
Okay, great. Okay. So first of all, thanks to Sonia and Rishi, who's on our work group. They really did some yeoman's work. They took the metrics that are in the program definition documents that we need to track in CPW and started working on how we can operationalize them. And the work group met and had a productive and vigorous discussion about some of the issues that are involved. So this is a high-level summary of the CPW metrics. And in general, they're pretty straightforward. The question is, what is the most efficient way to pull this data from the most convenient data source, and which items are going to require us building some degree of infrastructure in order to get it? So if we come down to table 2 in this document, well, the first one's pretty easy. Obviously, we're going to track the number of faculty and residents that we have at these different sites. That data we already have. There are various databases that the state and the LMHAs have that are already being queried on a regular basis. So it will largely just be a matter of a data pull. And this would be particularly true for items 2, 3, and 4, where you're basically looking at the number of client visits, the number of unique clients, and over a given period of time, we'll look at the ratio of unique children to unique adults, all straightforward. Now, in our original document, we wrote for metric 5, the change in child and adolescent wait list. And since our project focuses primarily on, or mostly on child psychiatry, we felt that needed to be monitored. Plus, I'm pleased to report there are no children and adolescents on any of the waiting lists. So we want to adjust that metric to be from the time of intake to the first prescriber appointment. Again, that is data that's already being tracked in a different database called CMBHS. Now, item number six, metric number 6 was a little bit more complex. A number of patients seen that were initially contacted through CPAN or TChat. So the HHSC is exploring whether a dropdown could be added to the referral source data that's already being collected. If people said that they came in through CPAN or TChat, that of course, that would require the parent to remember that's where they came from, and for the person doing it to always consistently use the dropdown. But we'd also saw it on the mirror image, anytime programs that had CPAN and or TChat plus CPU would make note of when they internally referred. So in San Antonio, if our CPAN, if our people said, well, we want to refer you to Center for Healthcare Services and we get you an appointment, we would track that internally. So you would really get, perhaps in some sense, 2 sets of data, % of kids coming into the LMHA that they identified as being referred from CPAN or TChat, and on the other side of the coin, the number of children in CPAN or TChat who were referred out. Now, the number 1 on our performance metrics, number 1 is number of residents who rotate who ultimately work for the community mental health system. That's obviously a long-term project. We're not going to be reporting on that this year or next year, but it does mean all CPW participants, should be getting in position to track where their residents are going, and to try, and at the time, certainly at the time of graduation, to make note of those who've taken positions with community mental health centers. Now, the most vigorous discussion has come up around clinical outcome measures that we will use. And I think there is consensus that we do want to extract data from the child and adolescent needs assessment. That's the needs, I can't remember what the S is, but the CANS is an interview that is done every 90 days in the community health center that looks at different levels of functioning. And the ANSA, the adult needs S assessment, that's the analogous measure in adults. These are well-established measures in the academic literature. The one concern that was raised both by Molly Lopez and also by some of the people at the LMHAs, we don't really know how easily these things track change. That each item, say depression or psychosis, is ranked from 0, no information, 1, no problems, 2, moderate problems, 3, severe problems. Does that really shift enough that it would be useful for our purposes, or be sufficient for our purposes? So that in turn led into a discussion about what type of other measures would be implemented. It's analogous to the discussion ongoing in TChat as to, are we going to use the Vanderbilt, the PHQ-9, other simple, well-established clinical measures that are in the public domain. The difficulty with this is that are these things already being obtained at LMHAs? If not, how will they be obtained, and more importantly, how will they be collated and reported? Now, talking with Laurel, I understand the intent in TChat is to modify TRACE so that it will have, people will be able to have their TChat participants log on to TRACE and enter these rating scale data. In theory, there's no reason why that could not also be done with CPAN if we wanted to track that more fine grain information. So that's kind of where we're at right now. I think we left this last workforce meeting, Beth Lowry was going to kind of do an inquiry as to which of these measures are already being, these outcome measures are being, besides the CANS and the ANSA, are being done at the Community Mental Health Center. And we were going to give more thought to the issue of what rating scales we would use and how we would collate them. All right, any questions? I'd particularly be interested in input on what do people think about obtaining a uniform set of measures in CPWE, kind of as we're starting to talk about doing in TChat.
Steve, can you hear me? This is Joe.
Yeah, go ahead. You could be a little louder.
I'm trying to understand how the goal of CPWE is that you're going to see more patients. Why you expect that will also improve outcomes for those being seen as a result of having more people doing more work, seeing more patients. How does that directly affect patient outcomes?
Well, I think we were sensitive to the idea that the legislature and the public would be interested, not only do we have more people working there, but it's had some kind of impact.
Well, at a population level, right? But that's a different question than within the clinic, you know? So yes, you know, in theory, you might say, well, if you had some estimate of, you got rating scales from everybody, and now you're treating the people who weren't being treated before, that you know, that you're having some impact. What about, did you ever consider any kind of satisfaction measure, or from the recipient's standpoint, client standpoint?
We worked very concretely off the metrics that were developed as part of the contracting process. So we weren't going to add, we certainly weren't going to add anything. Now, whether we can delete a metric, at this point, I don't know.
So Dr. Plitzka, you know, actually that's one of the, although described as a care experience tool, there were several tools discussed. I shared with you, you know, the meetings that were taking place that Rishi was involved in, agency involvement in a number of local mental health authorities, exploring that very issue, whether or not it would be possible, but thinking that this would be something that we would talk about in our work group meeting the next time we meet, just to explore some of that, to think about the possibility of a care experience tool as opposed to using the CANS and the ANSA in an attempt to measure outcomes for children with the limitations that have been raised. But also a recognition that those tools are tools that are commonly used across the local mental health authority. So it does provide a pretty rich set of information. It's just whether it will discreetly capture information, clinical improvements, certainly not something that could be tied to a particular resident, perhaps not even to the residency program, because we could have kids who are seen by residents, but who are also seen by other practitioners, and of course who get different levels of service. So being able to attribute to the program itself could be a challenge. But again, just more conversation, I think, to be had about that, general recognition of why the recommendation came around the CANS and the ANSA, and then we just have the conversation going forward.
So I think my plan at this point, and I think we do, I mean, as people are standing up their CPWE programs, we want to get the data collection in place. We don't want to delay data collection too long. So I'll probably be convening another CPWE group to follow up on all of these issues. any of you who have input for me, feel free to, you don't have to be on the work group. Feel free to email it to me and we'll certainly take it into consideration.
And I just wanted to add to Joseph's question. I don't think we're trying to show that, the CPW improves care, but I think it's just one measure among many to show that the kids that are in the services are getting better.
Yes.
Yeah.
Yeah, absolutely. It adds to the public health imperative to show, well, we're just not seeing more people, but the kids are improving performance in a variety of areas.
And those two assessment tools are comprehensive.
Yes.
They provide a lot of rich information. They're
indeed.
designed primarily for planning, for service delivery, and not as an outcome measurement tool, but nonetheless, being able to extract some information to provide really a greater context for people who are accessing services through this program. It seems to be positive. We just agree that there's more work to be done, kind of leave this conversation going, and recognize what we're trying to get to.
And this is Sonia. The other thing I would add to what's already been said is that we were trying to look at what already existed in terms of a way to track things, information that's already inputted. And the nice thing about this is that you already have an electronic system that can track that information as well as a tool. And to everybody's point, we don't know whether or not the CANS or the ANZA will exactly track the improvement as a result of the intervention that's being provided, through the resident services. But I certainly think that we could begin with this and start seeing trends. The other thing is that, if you have X number of kids that are being served and we see things, everybody's improving, then there may be some inferences that can be drawn there. But again, what my team tried to do is look at, along with the Texas Council, take a look at what do we already have, and what could be a good starting point. I do believe that there's opportunity to look at some other tools, but as you all know, if we start looking at another tool, that's one more thing, that the person on the other end treating that person is going to have to, put that information in. Then you're going to have a system to input that information and to collect it. So again, this is just a starting point, and it really does go well with the spirit of the strategic plan in terms of maximizing partnerships and resources that already exist.
And of note, there's no money in the CPW budgets for, administrative staff or research staff to collate stuff and input data. So that needs to be borne in mind as well. So that reinforces the desire to really use the data that's being gathered as part of the system.
And at HHSC, I actually have a department that tracks all of this.
And Dr. Ibrahim, I saw some email traffic from you related to what you need in order to move things forward. Does this help you move what you need to forward at UT Southwestern? He has some clinic responsibility. He's jumping back and forth, so he may have had to jump. He may have had to jump back off, but.
I'm just going to say that the answer to me from that, David, would be yes. I think this is very helpful.
Okay. And so it sounds like, Steve, just kind of wrapping up this part of the conversation, you have this plan as a starting point. It'll be refined a little bit more through additional conversations, and you'll be pulling those conversations together over the next month or so. And then Molly, have you been involved in those conversations, or do we need to have Molly part of that just in the internal analysis evaluation that we're all kind of on the same page?
Yes, I was able to be on that last call.
In fact, we've voted Molly onto the work group.
Okay, good. Very good. All right. Anything else, Steve?
No, that should do it.
All right.
I'll be a little bit more on this when we get to the cost, but this is the key aspect.
All right, very good. Why don't we go to the fellowships? And it doesn't seem like there's anything, Dr. Newland, to update on related to the fellowships. Is there, what, I don't want to assume anything.
No.
Elizabeth, do you have anything?
I don't have anything really new other than what we talked about like last time. So I don't, unless UT Austin has made some movement, which I didn't hear anything back yet. So.
Okay.
Yeah.
All right. So those fellows should be in the state of Texas seeing patients right now from the first group. And we're starting the process of recruiting for the next group that will start next July 1st, right? And I guess the other part of that was the standing up of the new fellowship programs. And I guess there's not really anything, unless anybody wants to update us. I doubt there's any major movement there yet. Okay.
I haven't heard anything, so I don't think so.
All right. T-Chat, I guess in some ways this gets brought into the cost discussion. Anything, Dr. Wakefield, outside the cost discussion that we're going to have in just a little bit that we need to bring up about T-Chat?
No, not that I'm aware of.
Okay. We'll bring that all into the next conversation. And then Dr. Williams, same thing with CPAN, right? We can bring that into the cost discussion.
Right.
On the research initiatives, Dr. Dominga, anything new?
Both of the networks are set up. They have their protocols written. Their protocols are going through IRB. People estimate that they'll have research subjects in before the end of this year, still in August of 2020.
Okay. I guess
just to remind you, the two, there's the Depression and Suicide Network, and then there's the Childhood Trauma. Those are the two networks.
And I guess, one point of business that everyone needs to be updated on is that at the last meeting, University of North Texas, and Alan, I'll bring you into this conversation in a second, but didn't think that they were going to be able to participate in the research initiative. And so there was some money that was set aside that we talked about how we could use it to benefit the overall research initiative. But we always said the first priority was if UNT could make us whole by being part of this, that we would use that as our first priority. After that conversation, Dr. Chassé, Dr. Podolwitz talked to some folks up in Fort Worth and figured out a pathway for them to participate. And Mark, I don't know if you want to say anything, or Dr. Podolwitz say anything, but they were able to figure out a pathway to join. And so now we have all those health science centers to be part of this initiative. Mark, is that a
yeah, I would say it's not 100%, but it's very favorable. We're very favorable. We're having discussions with our leadership, and I haven't been told any otherwise at this point. We're going to have some final discussions this week, but hoping the impetus of this being voted on or move forward today will also help with that.
It took a little bit of work finding the right people in the right places who are willing to do the right thing. Some young adolescent psychiatrists willing to engage, our director of research being willing to engage, who has also worked quite closely with UT Southwestern over the years. So she had some relationship there that she was willing to embark on. It's a slight shift in terms of our research areas, but not that big. We are fairly large in terms of suicide research, and we've been doing ACEs in our trauma forever here. So there are a lot of things lined up, and it was pointed out. So Mark is right. We're trying to get administration to figure out how they're going to do this piece, but we're well on the road. And I say, I'm glad that we finally got there, because I was worried in the beginning. And thank you, Carol, for everything you did to help convince Dr. Clausen that yes, she could play.
Well, Dr. Clausen used to be here really in our child program. So we do all know her, and we'll be delighted to reconnect and collaborate, help, all of that. Terrific.
Along the research lines, I did just want to remind folks, if your health-related institution has yet to sign your amendment, please get those to me as soon as you can.
So Mark, what do you need from us today? It sounded like you're waiting for something from this conversation. What do you need from us to continue that conversation at your institution?
I think our thoughts were is that I guess either operationally or if we need a vote in regards to the funds that would come this way, that would be the next step that the Office of the Provost and the Office of the Vice President for Research are looking for.
Okay, that's what I was wondering. And so we had money set aside, and we said we'd talk about it today related to priorities. But throughout those conversations, just like every other institution, we said that there would be money for that institution to be part of this. And this was our first priority. And so what I hear, Mark, is that we need to have a motion and a vote that those funds that were set aside in case the University of North Texas needed them to be part of this, but would otherwise be used for other initiatives, that we will, again, make those available to the University of North Texas Health Science Center to be part of this research initiative, right?
Correct.
Okay.
Is it to be a hub, right? No, a node, right?
A
node.
Node at the 250 per project.
But I think they're just one node. Is that right? Are you going to be both the research and the trauma node, or just both the depression?
Both nodes.
Both nodes. Yeah.
Okay, good.
So, okay. All right.
Now this, David, just for clarification, this is adding money to the original 10 million or?
No.
Nope.
Allocating.
This is part of the 10 million?
In the research budget, there was $350,000 basically that was not allocated.
All right.
And it was not allocated because the University of North Texas Health Science Center didn't think they were going to be able to participate. And we said that if they would not participate, that we'd come to the whole group to determine how it would be allocated across institutions, but that we would work and strive for the University of North Texas Health Science Center to be part of this. And so this would be solidifying that so that Mark can go to his provost and say they've approved those funds to be available to us. Okay.
Yep.
Does that make sense?
Now so that's not money we're needing to reallocate from anywhere. It was already in the 10 million.
Correct. It's already in the 10 million. Okay. If they didn't use it, it was going to be reallocated. Since they're going to be in, they will be able to.
We're voting to officially assign that money to them.
Yep.
All right. Got it.
David, the money that will move to assign them, since they probably won't start really in 2020, but only in 2021, would not be the whole amount as if they would have started early on. I think that because the research planning will have progressed so much, both in depression and in childhood trauma, by the time they get worked out to join, their startup will be fast. It's not like there will be any lag, but still they won't need any 2020 budget probably.
Okay.
That is correct.
All right.
It takes a
and
while,
Dr. Lakey,
as you all know, to work things through the president, to the provost, to the lawyers, to the office of research, to it. And things are fast tracked. They're waiting on their doorstep. But Carol, you're right. In terms of pulling a trigger tomorrow to start recruiting people, no.
Remember that we're right next door, Alan and Mark, so we're happy to reach across the 30 miles.
Okay.
So Luanne, you were going to jump in here.
Yeah, I was going to say, I think it's approximately 380,000.
That's what the minutes say, and the minutes that we just approved, it was 380,000. And so I guess motion would be that 380,000, up to that 380,000 would be made available to University of North Texas Health Science Center to participate as a research node in both of these projects. They will come back to us with the final amount of money, after internal discussions, but that 300, they'd be able to use up to that $380,000.
So I'm willing to make that, I'm willing to make that proposal, David.
Okay. So,
I'll second it.
So I think there were several people that seconded it, but I'm not sure I got all of them. So who seconded it?
Sarah Wakefield.
Sarah Wakefield seconded. So I have a motion by Dr. Minga. I have a second by Dr. Wakefield. Any further discussion? Hearing none, all in favor signify by saying aye.
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 Opposed, no. Okay, so Mark, it has passed. And then I would ask that you come back to us at the next meeting to tell us how that additional conversation proceeded. And again, if all those dollars aren't used, then we'll think together how they would be used. But we'll
And hopefully by the time this week's come, we'll work on getting the PIA and all that other stuff with working out with Luanne and team, etc. So thank you all very much. We appreciate it.
All right, very good.
Dr. Lakey, it looks like a couple people have raised their hands.
Oh, I need to look at the, okay, sorry.
Dr. Matthews and Dr. Ibrahim.
Yeah, so Dr. Matthews, did you want to say something?
Yes, could we get a copy of the final protocols for both nodes?
I have to say that they're not quite final yet. But the protocols are going through the IRB. The IRB of record for both networks is the UT Southwestern IRB. I think the request for we'll write it down that there's been a request that the protocols, once final, will be sent to the whole committee, and I think that would be great. Maybe we can send them to Luanne and she can send them around.
Also, Dr. Taminga, if you don't mind, I know the last time we met, we talked about that reciprocal agreement, IRB agreement, and if you could provide an update, I think that would help everyone.
Do you want me to do it right now or not?
Sure.
I wrote it down, just a minute, it's here somewhere. Yes. The UT Southwestern IRB looked carefully into whether or not it could be the IRB of record for each one of the networks. And they studied it carefully. They went to Western IRB, which is the other multi-site external IRB. And they finally decided that they could do it for the Depression Suicide Network and for the Childhood Trauma Network. And right now they have looked at the depression protocol, and that's just about what I heard on Friday night was that it was ready to be approved, and then the IRB is gonna keep track of what the group is really doing. And now they've started to do the same thing with the Childhood Trauma Network, and probably within a fairly short time, that will also be approved. And the UT Southwestern IRB will keep in track of what the protocol is, what the groups are doing, and what each of the nodes are doing as monitored by the group. Is that enough?
Okay.
Well, I think there was a question about the reciprocal agreement. Dr. Wakefield had specifically asked a question about that, and many of you the other institutions, just in terms of it was expiring and whether or not certain institutions were going to continue to be a part of that, or if there would need to be a separate process for IRB.
So the IRB knows that there is a group of institutions that are linked together that all can be approved as a single set, and then and they know that there are some of the sites that are outside of the set, and they'll just have to do more for the ones outside of the link. As far as I know, the ones that are linked together are still linked together. So there must have been a renewal there.
Dr. Ibrahim, you're trying to get in to the conversation.
Well, actually, I'm getting into the old conversation. You asked me a question, I couldn't reply. I was muted. if you don't, I just want to go back quickly to the CPWE discussion. We just want to say that if the sooner we can have final criteria and firm criteria, the better, because as I understand that this has been one of the obstacles for us to basically be able to recruit someone at MetroCare, which is our community mental health center. They actually wanna have the criteria. I want to know, how we would want to put them into operations. So it's been a little bit an obstacle to recruit for us.
So that the broader metrics, that's not sufficient for them. They're going to want even more detail than that.
I think if we if we are at this point confident that the broader metrics are the final ones, we could say that we can work together and put them into operation.
The broader ones are final. There won't be any added metrics to those, and you could also reassure them. I would just say those are them. So they're. And then I'll try to get it'll probably be another 2 to 4 weeks before the full operationalized metrics get to them. That will show them exactly how we're going to get them. I would say that anything they're not going to have to collect any data that they're not already collecting.
Yeah.
And if they want to put something like that in your MOU, that would be okay. Any data beyond what the LMHA is collecting that we as a consortium want, we're going to have to come up with a way to get it ourselves. So that's why we're being reluctant about jumping in to getting a lot of extra metrics.
Yeah, I think that was helpful to hear. So I think that should be enough. And if there is a need from their end to kind of have a little bit more details on operations, we can certainly reach out to you offline and we can talk more about it.
Okay, all right. I'll keep that in mind. And as soon as we define something more specifically, I'll get it straight to you.
Great, thank you.
Great, thanks. Dr. Wakefield.
Yes, thanks. So I see Dr. Trivedi on here, and Dr. Tamiga, I just wanted to clarify, it was my understanding from our last hub call with the Youth Depression and Suicide Network that the UT Southwestern IRB had decided not to do the reciprocal agreement, was instead doing smart IRBs and was utilizing the smart IRB and connecting with each HRI. Dr. Trivedi, I just wanted to clarify that because those are two separate processes.
That's correct. They are using Smart IRB, and 8 of the 12 are on Smart IRB. The other 4 are in the process, but our IRB head has gotten in touch with all the remaining 4 as well as the other 8 to set up a system. So you're actually right that they're pushing to do it through Smart IRB because the backbone of Smart IRB is strong enough to be able to monitor the 12 nodes. Their main concern are the adverse events and serious adverse events at these sites being monitored and documented and reported and all. And Smart IRB is able to do it. So you're right, Dr. Wakefield. They're using the Smart IRB.
Okay, thank you, Dr. Trivedi. I just wanted to clarify that. And then the other question I had was, Luanne, do we have, and we don't have to talk about it here, if you don't have this information, but about what stage each HRI node is in getting that contract back to you or the
yes,
agreement?
I have it. Okay. I can report it right now if you'd like me to.
Well, yeah, and because some people are reporting that it's difficult for them to get, because funds haven't been distributed, that they're not able to hire people. Right. That will affect our ability to start in August, even if the IRB is approved. And so that's
yeah. So in terms of fully executed, UTMB, UT San Antonio, Baylor, and UT Austin Dell are fully executed. We're waiting for signatures from the following HRIs: UT Southwest, UT RGV, UT Houston, Texas Tech, Lubbock, Texas Tech El Paso, and Texas A&M. And then as Dr. Chasse indicated, we'll be working with UNT around their node budget. And once that's completed, we'll get their amendment started. And then we're going to be working with Brittany for UT Tyler. So that's where we're at.
Okay, that's helpful because I know for us, I've been told that everything's done on our end and we were waiting on the UT system. But if that's not correct, or if other people are getting that feedback, we can help clarify and get that information back to.
That would be wonderful because as soon as I get them, LaShelle and I work them through. So.
Okay.
Yeah.
So Sarah, we may need to just check, make sure there's not some disconnect, that somehow somebody thinks somebody else is doing it. Sometimes, emails go to the wrong folder or something has occurred. So maybe after this, let's just double check. But from our records, we haven't received it. Sounds like from your records, you have sent it. Let's figure out where that disconnect is.
Absolutely.
And-
Luanne, if
yeah.
you wouldn't mind sending me that just an email with that information, then I can help
Sure.
the network make sure that the other nodes get that information and we
Okay.
get.
And then kind of finalizing this conversation, Carol, earlier on, you brought up the issue of peer review and anything about that you want to talk about? It sounds like one of those issues is compensation for the people that would be doing peer review. Any other issues related to it?
No. Well, the only other thing was a question. Really, Luanne and Nagla have really carried the lion's share of the work on that. And I was wondering whether we were now going to solicit people within the UT system as well as people from out of state, or whether we're still focused on people out of state. And then I was going to say that unless you give some kind of an honorarium, it doesn't have to be really big, but it could be something. You won't get really the best people to do the review. So I just wondered what Nagla and Luanne had to say about that.
So are you talking $1,000? Are you talking much more than that? Or what do you think?
No, 500, 1,000, yeah.
Yeah, and about 6 people, is that what the number was?
I thought there were 3 people per network. That's what Nagla and Luanne, even 2 people per network. So a total of 4 would still be good enough.
All right. Yeah, I think we can figure, I'll talk to Luanne and Nagla, but I think we can figure out some way to get $6,000 somewhere to do that. Okay. Luanne, did you have any comments?
I think also another question was, the scope of the recruitment, whether it's in Texas or national recruitment.
Yeah.
The nature of the research would suggest that national recruitment would be kind of appropriate. It would be perfectly fine.
It'd probably be good to have some people outside the state of Texas taking a look at what we're planning and give us, not that these aren't great plans, but have a eye looking at this that hasn't been part of this conversation and make sure that they, guide us. Okay. So we'll work through that, but I think we can.
Both Charlie and Maduker had some suggestions for who would be, maybe on a national scale, who would be really appropriate.
Okay.
Sorry, I couldn't figure out how to unmute myself.
That's right.
We'll be in touch with you, okay?
Great.
David, can I say something? Peter Thompson here.
Yes.
So we're having some issues that IRB will not accept any outside IRB.
Okay. So you'll need it'll need to go through both of those IRBs then, but both the centralized and then you guys will have to take a look at it too and approve it.
I don't think they would need to go through both. I think if their IRB will not accept the central IRB, then they just have to go through their own IRB.
Okay. All right.
Can I ask a question?
Yes.
So Dr. Thompson, that in that case, will your IRB allow you to deposit data into a centralized database or not?
As long as it's there's no PHI, I don't see why not.
Dr. Abraham, I see your hands up, and then Dr. Wakefield. And Dr. Wakefield just took her hand down. So Dr. Abraham, any other comments? Okay. All right, I take it he's probably having to do some other work right now. So why don't we, Carol, it sounds like there's nothing else on this conversation. We're ready to move forward to the next item, right? I guess the one thing that reminds me related to the peer review, if other members of the executive committee have people that they think would be very helpful, please send those to us.
Yes.
And so Dr. Ravetti has ideas, Dr. Nemiroff has ideas, but that doesn't exclude the rest of the members. And so if you have people that you think would be appropriate, send them to us, okay?
Luanne in particular had some ideas that sounded interesting to me.
Okay. All right. Why don't we move forward then to agenda item number 5 and have the update on the cost.
Hello, do you want me to share my screen to show my slides?
Sounds good.
Okay, let me try. Whee! How's everybody doing? Doing good? So quiet. All right.
We can see your slides now.
Oh, good. It's doing something. I don't know what it's doing. It's thinking about it. Somebody pause my screen sharing.
They may have been up from our team.
Oh, okay.
But they were up just a second ago.
Okay. I'm just letting it.
No, it's showing your email, Dr. Williams. Let me.
Okay, well, I was trying to get it to my PowerPoint.
You may want to stop sharing. You're sharing your email.
Okay. Yeah, I don't have anything. Thanks for telling me that. I don't have anything up that's like.
Okay.
I'm stopping it.
Okay.
But I appreciate that.
Sure. If you want, I can share your presentation.
Yeah, Nagla, why don't you put the presentation up?
Okay. I'm not touching it now. I'm waiting.
We can see them now.
Okay, I can't. Let me see. Because I don't see them on mine. Let's see. Well, so you guys can see the slides. I'm the only one who can't. Okay. Today has been fun with my computer not doing anything it's supposed to. Okay. I don't know why.
We can see your log in the pool.
Yeah,
that's your first one.
You're in.
Yeah, it's like my computer is frozen, and I'm trying not to touch it too much because then it just does more bad things. So
we can, maybe you can just pull up your PowerPoint on another screen, and then we have it here and just talk through the slides, and we can change when you're ready. We'll just make sure we're.
Yeah, no, it's just my whole screen froze, so it's I can't. I'm actually seeing nothing now. I'm seeing a whole lot of nothing.
Okay.
Jennifer, are you on?
No, I can. Let me just get to Task Manager and figure out what the problem is. Sorry for that. I don't think I'll take up too much of your time today. Oh, goodness. Just Dr. Lakey, nothing about my computer's working today.
Yeah. It's all right.
Okay, now I can see things. Yay. Okay, so first slide. It's the middle of summer. Hurricane season's here. We can't go anywhere because we have to be socially distanced, but we can maybe be in a pool. Next slide. So what we're going to talk about in the next few minutes is the telecommunications, data management, what's going on with CPAN and TChat, and then the statewide referral system process that we are looking to do. Again, we can see here that Dory and her friends are all appropriately socially distancing in the pool. Next slide. So CPAN, telecommunications. So we have completed the contract for Lantana with the state and Kosh to Lantana. Leighton Poley is the project manager that's been assigned from the Lantana team. He has created a schedule to meet with all the individual HRIs to talk with them about how to set up the 800 number at their locations. My understanding as of Friday, close of Friday, He had meetings scheduled with all but 2 HRIs, and he was circling back to the 2 HRIs that he did not yet have a meeting scheduled with. We had our first meeting as just sort of a preview to the executive committee. Baylor had our first meeting with the Lantana team about what needed to happen. We had about 10 people on the phone call, but it ended up actually being not too complicated. And just as Lantana team has said, we have to do a few things that Lantana Layton will do with your HRI's IT team. And then beyond that, it sounds like it won't necessarily be a horribly complicated process, which is why I'm knocking on some wood. You can't see it, but I'm knocking on wood. So I think that this process is moving forward pretty well when it comes to the 188 number and being able to use the full functionality of the Lantana system. Questions about Lantana? Okay. Going on to data management. We had a goal in mind that we wanted to have all the BAAs and NDAs signed by the end of July. I'm pleased to tell you that we're pretty close, and I do think it's actually very feasible that by July 31st, we will have all of the BAAs signed, which I think is a minor miracle. And I appreciate everybody's teams, your compliance and legal teams at each of your HRIs, as well as the team leads and the chairs, and helping make sure this process kind of kept going. So 6 of them are fully executed. The remaining 6 are very close. They're in their final phases, basically. The same thing with the NDAs is that they are pretty close, that are remaining ones that having all of that complete. We've also at the COSH completed our contract with the trait team for their services, and they'll be getting their first payments in the next several days. When it comes to the data management for CPAN in particular, I know there's been conversations about TChat. We'll talk about that in a little bit. But for CPAN, the step 1 was that the teams that had their NDAs could start to meet with Trade. Trade has reached out to all the teams and has set up meetings, and I know that they've already had several of those meetings in the last 10 days. Once people have their BAAs, then they can fully execute Trade in the way that is designed for CPAN. So that's another sort of teaser for why we want to have the BAA and the NDAs signed. So that process is going right now with the rollout to going and training all the teams on how to use Trade. Step 2 is the enrollment process for PCPs is complete, including how to bulk enroll. So for practices that are large, that have multiple providers in their system, they've created a very user-friendly system. We've already had some big practices use it and say, yes, it was very easy to use. That allows for us to bulk enroll a large group of people at once. That's now live. And then the actual phone call itself, part of CPAN, that piece is slated to go live this July 31st, this Friday. So that was Trade's timeline, and they've been steadily working towards that goal. And somebody's knocking on my door. I'm going to ignore them. Maybe they'll go away. No, they're not. Just 1 second. Just they were persistent. I wanted to make sure it wasn't something big. So the phone call piece of Trade will be up and running the end of this Friday. So what that means is that the whole system that Trade has created for CPAN will be delivered and done, quote unquote, this Friday. So a lot of work has gone into getting to this point. Very excited. Going back to Dr. Pliska's comment earlier about CPWO, one of the pieces of the CPAN process when we're talking to a PCP is we have a very comprehensive drop-down list of things that we're tracking that if we recommended for the PCP to do. I think that we do have a line that says an outside agency, but I don't know that we have one that says LMHA, but that's something that I'm going to take back to the trait team when I talk to them today at 4 to sort of say, you know, when you say referrals, can we add another line of specificity that doesn't just say community referral, but says LMHA? Does everybody find that to be?
Or I suggest maybe from, because from either for their LMHA in general, but also from CPWE associated LMHA, because that might be a distinction that's important.
Okay.
You can get referrals from any, but you only have a relationship with a particular one, unless they're all,
Right.
unless the overlap's going to be perfect,
So,
well, but I think for a lot of the CPAN hubs, your regions go out really wide.
Okay.
And so I don't know. So I mean, that's what I'm trying to figure out, like what level of specificity would we want to put when that's one of the ways that we're checking off that we've provided a resource recommendation to a PCP.
I think it would be helpful if it was really specific, if it had the LMHA name.
Mhm.
Laurel, I've forgotten what's BAA, what's NDA. Trait, I assume is the name of the company. And then
So BAA, Business Associate Agreement. So it's the document that we have to have signed. Is that what you mean?
Yes.
Okay. So it's the document that we have to have signed between Baylor as the COSH and each of your institutions, so that we can share data that has protected health information in it. And then the NDA is with Trait, the company, not with Baylor, and that's our non-disclosure agreement that you're not going to, learn their secrets and then go and build your own trait.
And PCP is it's just a local pediatrician, right?
Yes, so PCP, so we enroll pediatricians, family practice doctors, nurse practitioners, PAs under the work underneath or work with, I should say, a primary care doctor.
Got it, thanks.
Mm-hmm.
And Dr. Williams, I would echo what Dr. Newland said as well, and see if we could do LMHA, and then with the specificity of even just typing in the name of the LMHA. I think that would both help in comparing to CPWE programs, but also looking for future direction and supports for our LMHAs. But Danette, does that sound like something that would be helpful?
I think, but go ahead.
Sarah, did you say Danette?
I did.
Okay. I was thinking you did, but then I thought I might have misheard. So yeah, yes, it does. I'm trying to think the best way, and I don't know in terms of the data system. We do have component codes that are unique to each local mental health authority, actually each community mental health center specifically. And the component code could be used if it's a data system issue, in terms of entering the name. But I think it would be helpful. I'm not certain in terms of what the volume could end up looking like. And I was contemplating the connection to the workforce development, to the CPWE, and kind of thinking about what circumstances would exist in which a child is being seen by the community mental health center, even by a resident, and would be referred to CPAN.
I think it's the other way around. I think it's more we're talking to the PCP and they need a referral, and we recommend to them that they go and be seen at CPWEO. And also with TChat as well, that may end up being a recommendation, and then the PCP may learn about it because they are coordinating the child's care.
Okay, good. Thank you for that clarification. So then it's people within the program that are making a referral specifically to the community mental health center.
Mm-hmm.
And the question is whether or not it would be helpful to have the specific referral named, correct?
Correct.
Yeah, so I mean, from a standpoint of being able to track or know or understand what's happening out there, that information would be very helpful.
So I'll talk with the trait team today. That's what we've been doing the last month and a half, is refining what the tool looks like. I could easily see them, if we have the line for LMHA and then it requires our team, the CPAN team, to write in the name of it, versus whether or not they can load all the names of the LMHAs in for us to type in, because they do a lot of things they've loaded on to search. So I will definitely bring that up to them today when I meet.
Okay.
But we'll have the first sort of version 1.0 of the call form that's ready to roll out at the end of this week. So again, a lot of hard work has happened between now between, I guess, March and July to get us to this point. And I have some level of confidence that the HRIs that are almost close to their BAAs, for example, it really is at the very final step. It's been agreed on. The compliance team at the HRIs has looked it over, and it's going back and forth between Baylor compliance and the compliance team. So I also want to thank Lachelle and Christina over at the UT system, who oversees all of the compliance officers for UT, and really helping keep this moving forward, because I know there's a lot of competing important work being done with COVID that certainly makes it hard sometimes to get people's attention. So I appreciate all the efforts that have gone to this point in getting us here.
I think the same issue will come up with TChat, where we're wanting to track where those patients go. So if they did take the time to preload each LMHA, the
it helps there too.
Menu will be used over again, and it will be easier to extract the data on the back end probably if it's a preset menu.
Okay. I'll definitely, I'll talk to him. Yeah, Dr. Lakey?
I was just going to note that there's only 39 MHMRs, and so it's not like it's a huge list, and so it should be pretty easy for them to put it in. And drop down menu to do it.
All right. I will, I'll bring it up with them today, because that's what I said, we're doing the fine tuning with the process right now. Okay. So yes, I'm very pleased with just how much things are really kind of moving along despite all the hiccups that we would normally expect, and then the additional hiccups. Anything else about data management for CPAN? Okay, next. So the TChat data management. So TRAIT, we built into the contract for TRAIT for them to do an additional work around connecting CPAN and TChat together, so that if we saw a kid through TChat and they ended up they had mild to moderate mental health issues that their PCP could manage, not the moderate to severe that may go straight away to another referral source, that they would be able to do some engineering to be able to connect that TChat process back to the physician who's in CPAN. So that's something that they're going to start working on. The other piece of the data management is the pieces of data that we have to report to the state, just to talk about TChat at the level of what was required in our report from November. So what we want to be clear about is that data collection is not going to be research, and it's not going to include PHI, PII. We are definitely not working to include those data elements in creation of the data system for TChat. So what you see in this slide is the things that are in red are the things that we think can easily be built in the TRAIT platform that doesn't require a lot of effort on TRAIT's part, because it's sort of in line with what they already kind of do with their system. But these would be things that we would put in that are the metrics that we have to for the state. Numbers 1 and 2 are just data points that we get already from the HRIs who have been sending to me what schools they're going to be in across their region. And then obviously how many kids are in each of those schools. And so those data points are things we don't need to get through TRAIT. But just like with the conversation with CPWIA, what we also want to do is eventually have a system that's built that lets us look at things beyond how many kids were served, what type of provider saw them, and what happened with them afterwards, but actually try to say something about the progress of their care. And so that's the other thing that is what's uniquely suited, that TRAIT's uniquely suited to do, is do that piece of it. So the red line, the red things here are things we must report to the state, but we also will be working to report some additional metrics about actually how are the kids doing beyond that we saw them and they saw this type of provider. Next slide.
Well, actually, before we go to this, Laurel,
Sure.
That I think comes to a key point for both TChat and CPWE. So let's very concretely, if we're going to measure a PHQ-9, if you're going to collect that data in TRAIT, then I'm assuming there'll be some kind of, if there's not going to be PHI, are you going to want us just to put in patient 1, San Antonio TRAIT patient 1, PHQ 12, And
No, what I meant by PHI is your team will see the PHI. You won't send it to me at COSH. So at COSH, we're not going to ask to look at your patient PHI or PAI. So we're not asking that data to be sent to us. You can see that on your end at your institution. So yeah, you don't need an extra additional number. There'll be one created, for example, so that the data can get reported to COSH.
Well, that was, I mean, so every time we enroll a TChat patient, we're going to enroll something in trait with a code number with no name or PHI.
No, well, so what's going to happen? I'm sorry. What will happen is you will send the trait link to the family. The family will fill it out. They will give you all the information that you need about that family. But what trait will do is when I need to see it or when COSH needs to see it, they will send it to us in a de-identified manner. So we're not looking at PHI.
So that patient record creation occurs when we send it to the patient. Okay.
Right.
All right.
Yeah.
Very good.
Yes. So we're not, the COSH does not want to see, because we didn't want anything that looked at all about PHI or PAI.
Mm.
Okay. Good question. Data management, governance. So we did have to search again for another co-chair so that Dr. Plisko wasn't having to run this by himself. And so I had put out a call and talked to Alex. And Alex agreed that he would like to participate if was so elected. So I think we're at a discussion point right here with the consortium that we need to consider Alex Vo and whether or not he can be co-chair on the data governance committee.
Okay. So it sounds like I have a motion that Dr. Vo be the co-chair from Dr. Williams. Is there a second?
A second.
Okay, second from Dr. Wakefield. Any further discussion or any other candidates want to put their name in? Hearing none, all in favor of Dr. Vo being the co-chair of the Data Management Committee of the COSH, signify by saying aye.
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 Aye. Aye.
Opposed, nay. Congratulations, Dr. Vo. You're the co-chair.
Thank you. I'm very honored.
So I wondered, Alex, if maybe you could go through the governance team's goals and objectives that are listed here briefly.
Sure. So we had a preliminary meeting, like what Laurel just mentioned, on May 14th. But essentially, the goal and objective of our data governance would be really, if you look at data management as a logistic of data, data governance is really the strategy of data. So our main goal is to offer better visibility to both our internal and external customers, making sure that we're in compliance with regulatory laws and essentially determining exactly what is acceptable data, where it's located, how it's used. So creating policies around ownership, stewardships, and essentially making everything very transparent. So these are the 12 steps and this is actually derived from the Data Management Data Governance Institute of how they recommend a group like ours go about looking at data, especially complex data from multiple institutions, and how we put in place policies and accountability for how the data is used. So essentially, I think what we're going to end up doing fairly soon as we get to convene the work group or the committee is to kind of run through some of these processes.
Thanks, Alex. And what COSH is going to do is that we'll be sort of helping convene the meetings, keep the minutes. If there's some sort of work that needs to be done around this, Drs. Pliska and Vo can look to us to kind of help them with that sort of project support so that they're not needing to do it themselves.
Yep, looking forward to it.
Great. Next slide. So to date for CPAN, we've enrolled about 1,500 PCPs across the Texas. We have 9 teams that are currently taking calls. We are still averaging around 2 to 3 calls per day, and they're not focused on any particular region of the state at this moment. The remaining teams that have not yet started do have plans to start in the fall, and so we will be excited to have them come on board. Again, Trait will be up and running, Lantana will be up and running, so it'll be a good time for the remaining to get themselves on board. Next slide. We're doing a lot of work, and obviously when it comes to communication about CPAN, as well as strategies for engagement with the primary care physicians out there in the world. We will have a Facebook page for CPAN that will be ready to go next week. We're working on that. We had talked with Dr. Lakey and his team, and then we talked with Baylor's team around social media and communications, and we are following the procedures and policies that are laid out by both entities for having a social media presence. This will be the state page, though it's not specific to Baylor. And so each of the CPAN teams across the state are invited or asked actually to participate in helping us give content so that we can we'll have 2 to 3 posts per week that will come as a result of our state Facebook page. So we're very excited about that. I also have been working with Dr. Tran, who is our PCP consultant for COSH. We're going to make a video, and weirdly enough, Dr. Goodman, I didn't tell you this earlier, but Baylor is letting us do this for free. They're not charging us to make a video. We kept asking a couple different ways, and they kept saying, no, we'll do it. So she's actually driving down from Austin. We'll be socially distanced. We'll practice social distancing, but we're going to tape a video that explains CPAN that we will be able to put both on the Facebook page and then also on the web page once we have that web page that we're working in collaboration with Dan's team about. So we're pretty excited about that. We're going to have the last page of the video that we create. We'll have all of the HRI's logos. And so your CPAN team should have got a message to us. Can you please send us one of your approved logos so that we can put that up on the video link. We are working on a contract with Texas Pediatric Society for them to help blast and provide information to their constituents. They have about 5,000 primary pediatricians that are in the state of Texas, and they have a pretty good click rate for when they send something out to their pediatricians, that pediatricians look at the stuff that they send. So we're really excited to be working with them. Even though their conference this year is going to be virtual, Dr. Tran and I are presenting at the conference, as well as we will, as they figure out what they're going to do for vendors virtually, we will also participate in some form or fashion with their new format that they're going to do for the fall. But subsequent meetings will have a booth with CPAN materials, and myself and others are sitting there, answering questions to primary care doctors. We've already been doing communications with the Texas Family Physicians Group. I've done a blog with them already. And then Dr. Lakey, myself, and Dr. Tran had a meeting with the medical directors of the state Medicaid programs this morning. Despite technical difficulties, I think they got some information that were hoping to hear. And we are still working to set up a meeting with the FHQC leadership to help get CPAN out into the FHQCs. Next slide. Marketing, we did sort of poll our CPAN teams, and what we've decided to do is order in bulk because it really brings the prices down. With magnets, you see up on the right-hand corner is Dan's treatment of a magnet that has the CPAN logo and the number, along with badge holders so that you can say CPAN on their badge holder. Those things are pretty small and easy to order in bulk, and you can only put the CPAN logo on it. So those are things we're going to order from the COSH, but each of the individual hubs, in their own efforts to communicate and market to their regional team members, they can use their sort of internal budget to maybe do different items that they could potentially put their own HR logo on in addition to the CPAN logo. So we're working on that process right now. And then we are working, so Dan hired a new person to help with the development of the website. What I thought was interesting, Dan, the last time we had a conversation where you sort of showed me what the click rate was for MCPAP, the website for MCPAP. And what the analytics kind of showed is that the most common reason why people go to that website is still to find the phone number to try to communicate with MCPAP. So we're excited to move forward with probably sometime in September is when we'll have the website be live. And what we decided to do is have 4 teams across the state of Texas who are working on content. So we have some team members working with me on the face page, and one of the things that will be on that face page is that video that Dr. Tran and I are creating. So the first thing you see when you go to the CPAN webpage will be this short introductory video that's less than 3 minutes that explains what CPAN is from a PCP's perspective, as well as from the perspective of myself for CPAN. And then we're going to have 3 tabs to start, one with depression, one with anxiety, and one with ADHD. And we have teams that are working on the content for that. And so once we get that content in, then we're going to work with Dan and his team about what's the best way to present that content that's user-friendly, that helps people click and get the stuff that they want to get. We decided that we weren't going to try to build everything at once. And one of the reasons for that is two reasons, I should say. One is strategic. Once we put in new content, then we have another reason to send a Facebook link out or another email blast. Hey, go to your CPAN webpage. We got new content. And 2, just we don't have enough hours in the day to get all content up at once. So we started with what we thought were high yield areas of content, and we're moving forward from there. Next page. Anything else about CPAN before I go to TChat?
Laurel, I have a quick question on the marketing materials. This is Brittany.
Sure.
Are we, so I'm hearing you say that y'all are creating some materials that we could add our own logo to and purchase. Does that mean, do we also have to go that route, or can we still create our own separate materials? And I'm asking because we're in the middle of conversations with public affairs on this right now.
Right. So the things that we decided at the state level to do are the magnets and the badge holders, because they're small enough that you can't put 2 logos on. So we're just going to have it branded with CPAN. We were potentially going to use our cost money to get that, and then we would distribute it to teams. You can use your monies that you've maybe set aside already within your budgets to do other materials, and then whatever other materials you want to do, yes, please do.
Okay. Okay. Thank you.
And Brittany, I was going to say just quickly, you know, we don't want to get in the way of people doing the stuff they need to do, but we are hoping that people will stick with kind of broadly our branding guidelines. So
yes, no, we were thrilled to get the branding guidelines.
Okay.
So we are absolutely using that and want everything to complement and not design anything that's going to go too far off track. Just, you know, just having some separate UT items.
Okay, and I was I'm just wanted to interject that probably tomorrow I'm going to send out an email with info on the Canva system that we're developing. That's not for things you're going to want to like print, like magnets and bags and things like that, but in terms of paper materials, you know, social media graphics, one-pagers, things like that. That whole system is designed for you all to be able to customize it with your institutional logo and colors and so on. So that should be tomorrow or Wednesday is when I'm going to send out an email, and I'll just need to get a single email address from each institution that'll be your login for that. But just a heads up that that'll be coming your way.
Okay.
And that'll enable that stuff.
I think it would be helpful just generally, and maybe for other institutions as well, to know. So we don't like know ahead of time that something else is going to be coming out like tomorrow. So we're trying to finalize with public affairs, but we want to know if there's still going to be things coming out for us to utilize that we need to tell public affairs. We need to hold off until a certain date, because we're going to be getting something else from y'all. So I just want to be sure that we don't, for example, spend money to print something and then something else comes out for y'all that we would have wanted to utilize. So I don't know if there's kind of a timeline or already some dates when all of that stuff will kind of be out and done, but some of that may be helpful to know.
Okay. Well, that initial stuff, the Canvas stuff, is going to be this week. We'll be adding stuff to that. I can try and, I mean, if there's specific kinds of things that I have a sort of timeline on, I can try and share that. Laurel, I don't know if you said when the magnets and stuff are going to be out. I mean, to the best of our ability, we can share kind of what the timeline is. The Canvas stuff I can share with you, as I said, this week, and you can share that with public affairs and figure out if there's anything else you might need. And again, don't want to get in the way of anybody developing their own materials. Happy to take requests as well. What we're putting up on Google Drive and on Canva is in some cases things that people already developed that we adapted, and otherwise it's just our best guess at what you might need. But we're also willing to kind of take requests in terms of things that you need that we can do.
Great, thank you.
Dr. Williams, before you go further, I think Shannon is trying to get in and has a
Oh, sorry, I can't see I just see the slide.
That's okay. Thank you, Dr. Lakey. And Laurel, I just have a quick question. On slide 7, it states that there's 1,500 primary care providers that have enrolled, and that's awesome. Question is, the 2 to 3 calls that you're receiving per day, is the difference between 1,500 enrolled and 2 to 3 calls a day, is that just kind of getting the word out to the providers that are enrolled? Is it all just the newness, or what is your expectation in terms of numbers of calls now and in the future?
Well, I think that there are 2 different things, right? So one is getting somebody to sign up, and the second is getting them to use it. So we're excited that we're getting some people to enroll, but we also now need to get them to use it. And so everything that we've talked about with the other CPANs across the country, it's about the ground game that's on some level been a little bit diverted with COVID. So I think that there's a little bit of play here that COVID is make it hard. I can't go to a PCP's office and drop things off and talk to them about it, because COVID. So I think that we don't want to obviously blame everything on COVID, but I do think that that's a piece of it, is that some of that process of getting them to know us and not just know the name CPAN, but know us and trust us is a little bit harder when we're struggling to kind of be able to get in the door and talk to people. That being said, we are working on strategies to get our foot in the door after they've enrolled. So now that we have their email addresses, they've enrolled, we are reaching, we want to reach back out to them and say, hey, remember us. That's why we're getting the Facebook page. We'll have the LinkedIn page. We'll have the web page. And then we're starting to use the TPS and Texas Family Practice team to help get the word out as well. We're hoping that will bring some additional traffic to us. When we talk to, for example, the Massachusetts program, it took them a year and a half to really be fully busy. So I don't think that I'm worried that we've been started since May 18th, that we're kind of at this average. I would be worried 6 months from now if we're still at this number, but I don't think that at the beginning, when we're right at the start, that we only have a couple of calls a day. I'm not worried at this point.
I do think COVID, it's more than just us getting the marketing in the door. I think people are now only taking their child to the pediatrician for the most acute of illnesses. And like well child visits, school problems have decreased because the kids haven't been in school since March, basically. And that natural thing that tended to drive people to the PCP, a crisis at school, go see your doctor, those things are not there. And that's gonna, even if they have our magnet right there in the exam room, they may not be getting the input from patients that are gonna trigger them to pick up the phone. So we'll have to see. That's something we're gonna have to think about as well.
Yeah.
Laurel,
so go ahead. Any input other people have, though, we're welcome to hear it.
Yeah, Laurel, this is Sonia. One of the things I thought about that might be helpful, we have some resources that are attached to HHSC that I think might be helpful, like 211. They get thousands of calls on a daily basis from all over Texas, and some of those might actually be, maybe not the doctor themselves, but maybe somebody from the doctor's office. So that's one source. And then we have an early childhood intervention program that has a lot of, interaction with, programs and so forth. I think that could be another. And then I don't know if our coordinating council could be helpful, But if there is any basic material that's already written, and you guys may have already sent this and I didn't think about it until just now having this conversation, if you send that my way, I can make sure that, that gets, pushed to those areas. And the people in charge of those areas, I work directly with them.
Great. No, I'm happy to send it to you. I think what we're noticing with the work that we've been doing to date since May is that when we actually finally talk to a primary care doctor and tell them about it, they're very excited and they're like, oh my gosh, this is the best thing since sliced bread. But we are definitely not getting their eyeballs. And I do think that, so again, the blog that I did for both the family physicians and the PCPs, one of the Medicaid teams that was doing was actually, you're on a Zoom call with the family and something comes up. Here's how CPAN can help you, because we want to make sure that they could see how it might work in their day. And that's the other reason why we want to make the video, is we want to be able to show people how this could work in your busy practice, whatever your practice is looking like right now.
So Laurel, as you've been talking to physicians, have they been describing to you what we hear? This is kind of following up on what Dr. Pliska was saying, substantial reduction in terms of people, just broadly speaking, but I think this would apply for families with children as well, not seeking care right now, just, and in some instances, I mean, we've actually seen quite a few private physician practices close, at least temporarily, or substantially reduce their hours. So it seems as though we really may be also experiencing a substantial reduction in the number of kids that primary care physicians are seeing.
Yes, I would say that the call I was on right before this would echo your comments as far as about that. But again, that's why we also were talking about, like, particularly if your practice is still running, my chart doesn't stop running, phone calls to your practice don't stop running. So we also really want to show to the PCP, like, you can use this even if the kid's not in the office, but you have a question. So I think on some of it, what we keep hearing time and time again from all the states where CPANs are running the most successfully is that the build of those relationships with the providers in the region that you're sitting in. So we don't want to have too much of a top-down approach or spend too much money in a top-down way, because we're not sure that that's the best way to sort of communicate. But it will be over time. We'll have both the top-down, where we have some things that are at the state level. There's a Facebook page. There's a website. There's some stickers and things that we can provide. But then it's really allowing for those teams to develop those relationships. And that just takes a little bit of time. And I think COVID has made that more challenging.
Yeah, I think we can safely say that there has been no program in other states that was launched in a pandemic. So
probably not.
I'll just add one thought, and I think it's actually really great that you've enrolled so many providers. When we talked to the legislature about the consortium in general and about CPAN, we talked a lot about Harvey response and about Santa Fe shooting and about trauma in school-age children in mild and moderate cases. And so I think although COVID is creating some issues with parents taking their kids to the pediatrician, I also think you're going to start seeing parents with children facing some mental health issues that they haven't faced in the past. And so it may be that we're not seeing that volume yet, but I would expect that you would. And so I think, what we were promoting to the legislature is coming to fruition, unfortunately, with another issue that's going to be affecting all kids across the entire state. And so I think CPAN is really well situated, and all those PCPs enrolled at this point are really well situated to handle this new unfortunate population.
Yeah, I do just think that they were trying to grapple with the new world that they were in as
Sure.
docs. I know people that jobs were lost, definitely productivity went down. So I do think that those things are a factor, but I don't want to oversell that it's only COVID. It's really this idea that we are a ginormous state. We have a lot of real estate to cover, and it does take time to really build up. So we're trying to use all the tools that have been suggested to us from the other states about how to do that engagement piece. And I do think that we're going to get there. But it's definitely, it's in the early days. And so that's kind of where we are reality wise. And there was a question about what's happening if TRAIT's not up and running. Remember, we're using REDCap as the backup. So right now with teams that don't have because nobody has part 2 of the TRAIT form yet, we're using a REDCap form that will, all the data we're collecting in REDCap will migrate to the TRAIT platform. And Lantana is up and running. It's just they field the calls all to Baylor, and then we transition them over to the team that needs the call based on where the PCP is calling from. TChat. So we have, I guess I neglected to say, with CPAN, we now have a statewide CPAN meeting that all the CPAN teams will come and we discuss various topics. The one that's most recently been on our mind is engagement. And we do have some team members from Meadows who are in that conversation to help us think that through. But we also have a statewide TChat meeting. So all the team leads for the TChat initiatives in each of the HRIs come together for that. We had our meeting 2 weeks ago now for TChat, and what we discussed at that meeting was the idea that we wanted to have some measures that we'd all agree that we would be using. This did not mean that there couldn't be additional measures that teams wanted to use, but that we thought sort of our priority types of issues that we'd be seeing kids and adolescents for would necessitate outcome measures that we're all kind of using the same one. So I'm pleased to say that there was an agreement with the state TChat teams around the measures that we would use for suicidality, substance misuse, depression, anxiety disorders, and disruptive behavior disorders. So those measures will be ones that we'll all use when the kids have that particular issue or issues that they're dealing with, that we would be looking at their outcomes just to track to see, are they getting any better or not? So we're excited to kind of go with that process.
And just in theory, in CPWE, we could do the same thing if we chose to do it, but we're not at that point yet. I think our work group needs to really work that through a little bit more.
Sure. And again, and to be really clear, these TChat measures are not part of what we have to report to the state. This is the sort of second order. So we are definitely going to report the metrics that we're asked to report, which I showed you in that earlier slide, which is number of schools, number of kids that could get the service, and then actually how many kids are getting the service, what type of service are they getting, and then what kind of referral do they need after the service? And then do they have any trouble getting that referral? So those things we're definitely collecting, but on top of that collection, we're also wanting to see how are the kids doing? Because we do think that that'll be something that the state will be interested to know. So we're excited that we had an agreement there on that process. Next slide.
Well, just a question about measurement. Was there any agreement at what intervals you try to collect those types of data for? Yeah,
so we're creating a, I did tell you, and the problem is it's just, we've gone back and forth with it because personally, it would be sent to me, I didn't like it, so they've been fixing it. So I'm hoping that sometime this week, I'll send it out to the TChat teams for you to look at as far as the intervals of when we're checking these things. And again, my goal with the TChat teams is to get your feedback, and then we can come to a consensus. So I'll send something out, and then the team will provide feedback, and we'll get to a consensus.
Sounds good. Thank you.
So what are we doing at the cost level for TChat? We are working on the workflow of when to send the measures out. Thank you for queuing up my next slide, actually, now that I'm reading it. We have created a new consent form that we've talked with our legal team here at Baylor about. Again, it's something that you can use or not. These are things with TChat that we know sometimes your HRIs will have very specific ways that they want to do things. And so we don't say it here that you have to do it our way, but we provide these things for you. We're also working to develop medication guidelines for those TChat teams who are potentially going to provide psychiatric referral and assistance. We're developing an actual discharge intake process is already done via trait, but the discharge process, that would, again, hopefully allow for the family to leave the TChat services with something concrete about what was done during their time with us, and that actually could be connected to their CPAN PCP, so that the CPAN PCP could also see that same document and know kind of that their kid that they see and treat was seen through TChat in this way. And so those are the things that we're kind of working on, and I plan to show them at our next meeting.
Yeah, just to clarify on the PHI piece, because so let's say this is analogous to the rating scale. So I do a discharge summary in TChat. When I go to enter, and it's something I'm going to send to the pediatrician, so obviously it's got to have the patient's name on it at some point. So I'm entering the patient's name into trait. I fill out the discharge summary. I hit the button. I print it out. What you're saying is the name's being stored somewhere, but the COSH can't see the name. Is that correct?
Correct. Yes. So you're not going to send us the data we're not going to get data that has that information, but you at your team level for both CPAN and TChat, because you're in that region where we've talked before that there's the TChat region lays on top of CPAN, but we know that it's not always exactly contiguous, and you're not doing every single school in your region.
The file,
that way the PCP could have that information. Great. With parental permission, obviously.
Is it that the name is in a file that's in the trait server, but you can't see it, as opposed to the names in a local server, and that's the way it's separated? I'm trying to understand how that wall is maintained.
Well, sometimes, Stephen, if I may, I mean, sure, some of these things, there's a provisioning of access, user access that occurs when you develop this type of software. So they can actually set forth rules as to who can see what and who has what role, et cetera, and who can access what kind of information. So that can be done from a developmental engineering perspective.
Yeah, but that's kind of my point then. It's one database sitting on trait with different levels of access. That's what you're planning, or
yes.
That's the most likely solution.
Yes.
Okay.
So that is, yes, that you would see your local data, but the COSH would not see that level of detail.
There wouldn't be a split database that are linked in there, any of that. Okay, great.
Nope. And we've also been, again, legal, a lot of things related to MOUs and legal become very HRI dependent, very ISD dependent, but as much as possible, we have some ones that we're standardizing, so that if you're not already having your MOUs done and you want to look at some examples, because you have a couple of examples now, then the TChat teams could look at those examples. The other update that we wanted to bring up was that we've been having conversations with a number of the HRIs around what to do when schools don't open. So you can see my thing up here. Skipping school in 2019 meant going off with your friends and hanging out, but skipping school and right now just means turning off your computer and not doing anything. If schools are going to sort of continue to either have a hybrid or potentially some kids are never going to be on campus, how do we ensure that families that could use our service can get our service? And so we've talked about, potentially being on websites at the HISD level or the ISD levels to say, if your kid, if you think your kid is struggling, you could potentially, and we would be a list of services, and then the family could choose us. And then we ask the family, what school do you sit in? And then we report that. But we wanted to hear, because I do think that's been a question that a lot of the HRIs are struggling with, is what do I do if kids are really not back in school? But this is meant to be sort of a school-connected resource.
I think we had planned to market directly to parents of, if you're in the school district that we're partnered with. So we would, rather than we don't want to have our clinicians sitting around doing nothing. Somebody calls in and they live in the Northside District, we can say, hey, we got a program for people in the Northside District you can get into right now, as opposed to sitting on our waiting list. And we would bring them in, and then we would contact the school with the parent permission, of course, and say, you know, that we enrolled this person in TChat and now you can participate. I don't, you know, because the schools, it's going to be much more difficult if the school's all online. It's a lot harder for a teacher to identify a problem and refer it up the line. And we could really be in a bad situation where we just have minimal referrals altogether.
Yes, other thoughts people have?
Hey, Laurel, this is Danielle. Can you hear me?
Yes.
And so we had kids that we followed even in the summertime while school was out. And so we've got our direct-to-consumer platform. And what we found was connecting with students outside of the school, it works, but some of the nuances that we had to make sure we accounted for was if we had a child scheduled at a specific time and, you know, the child is asleep and they missed that time. And so there's not a counselor that could pull a kid. So, you know, obviously connecting with the parents and families are going to be critical if they are not at school, just for the purposes of making sure that there is continuity of the scheduling and that they, you know, can get to their appointment and all of the communication back to the school as well. So our expectation is that we will continue to do that if there is a, you know, school at home and the kids are at home as opposed to in the physical school building.
Yeah, I would echo that. We continue to provide services here as well. And we had more no-shows than we have when a kiddo is in school and they're being pulled out of class. But it actually worked pretty well where we just Zoomed into their house. And I would say, I know I've talked with you, Laurel, about this and some others that sometimes it was actually it was really, really great as telemedicine, as we've all been learning about telemedicine into people's homes, that sometimes they're more relaxed, they're more willing to engage with you, they're more comfortable. And so, and you get to really see their family and some other interactions, and might show you their room and that kind of thing. So a whole new set of kind of guidelines and procedures that you have to think about there, but that didn't, you know, we were able to flex and do that. One of the other things that we've been thinking about or planning on in talking with schools is loading it. A lot of the schools in our area are using Chromebooks and loading once trait is available in the app form, like seeing if we can get that loaded onto their Chromebook. So the child or student, if they were feeling overwhelmed, could access that. So you would do a general consent form at the beginning of school, like this exists, and your child could access it and have it linked to a parent or guardian so that it would trigger that. But so that's just something that we're thinking through. We don't have all of the logistics for it just yet, but yeah, I think we all have to think about what to do for the kiddos who are not going to be physically in school.
So Dr. Lakey, you're okay with the sort of idea that the way that some of the referrals can come in don't start with the school?
I think so. And Shannon, if you disagree, let me know. But again, we want to make sure we're using these resources best we can in the midst of this, really, you know.
Because that was anxiety from several teams. So I just want to make sure that we're really clear that the teams, you're allowed to, you know, get the kids in different ways that don't have to relink directly from the school referring them.
I did have a question for Danielle or others who are doing this, the direct to consumer. How do you actually have ways that the family can contact you directly without going through the school? Or are you only seeing, you know, children that have already been referred from the school?
Great question. And we have both right now because of the summer program that we continue to offer. There are a lot of ways in which families know that they can access us. But certainly we are preparing for, you know, a good portion of our kids to not go back, as we are hearing from our school partners and our families about what their intentions are. And so we'll just make sure that there are multiple ways in which we can be reached for services, recognizing that it is a school-age child and likely in a school that we support.
Okay, thank you.
I think some of the same rules, you know, I was kind of thinking through this, Laurel, and again, Shannon would love your thoughts, but some of the same rules will need to apply though, right? And that this was for a short-term intervention for kids that are in trouble, that, you know, I guess if the parents see them in trouble, et cetera, is not to take over long-term outpatient services for these kids. It is the nuance related to the time and tweaking it, but not, you know, changing the model so much that it's no longer T-chat, you know, and direct to kid services. I think marketing, letting them know, you know, letting the schools help us market it. I think all that is fine, but staying within those parameters of this is short-term intervention and then linkage to care, and that further linkage to care is no longer T-chat, but is paid for some other way.
Correct.
Shannon, what do you think?
Sure. I mean, I think obviously we did not anticipate quarantining when this bill was written or when the appropriations were given. I think, you know, this was meant to be an intervention for the schools. When the school felt there was an individual in the crisis setting, they had a place to refer them. So I guess in that scenario, how would the school be involved or engaged?
Well, and that's so how we typically in the past have done it, where even if a PCP has called me and said, you know, I'm really worried about this kiddo, and I say, you know, there's not a time in my private clinic, or there's not a time in our clinic that we could get them in for the next 6 or 8 months, but there's this other program that they could be assessed by an LPC and triaged and be seen much more quickly. What school do they go to? And the PCP tells me what school they go to, and I say, yep, we're in that school, here's the contact. And so then the parent will then reach out to the school contact and make contact with the school and say, hey, we're interested in this service. And so that has happened too, because sometimes the schools aren't aware of the crisis that the kiddo is in, and it presents to the pediatrician instead. And so I've given the pediatrician some recommendations, but, you know, for safety right in this exact period, but it does seem like the kid needs not hospitalization at this moment, but more of an evaluation. And so this is the way in which, when Laurel has looked at this, like the way in which to connect, that trait, being able to connect T-chat and CPAN is very, very helpful. In addition to looking at the app base, if trait can go on one of the, you know, things that the child brings home, whether it's their cell phone or their I mean, we haven't really talked about their cell phone, but I think that that's another thing to talk to Trait about. Would you be able to then, could it signify their parent if they filled one out, and a person at school, and that you get consent for that all up front? That doesn't mean that they're consenting to the whole process, but just that they're consenting to the school being notified if the child fills out a PHQ-9 or a suicide screening questionnaire or an anxiety questionnaire via that platform, you know, that they can access on their Chromebook. So our intention is still that the school is looped in that way, that it, and, you know, those logistics are yet to be worked out for the fall, but we're looking at all of them.
So same here, Sarah. We still connect in with the school and the counselor if the school is in session.
Okay.
I think what Sarah just outlined, from my understanding of the bill, would be consistent. And so you're letting the parents know that the service is available. And if they see that a child needs help, their child needs help, talking to the school and then getting the contact in to our academic centers. So the school is looped in, but the person who knew about it was the parent and made it happen.
Yeah, because I have serious doubt the schools are going to go live before it's spring of 2021. You know, I'll just be frank. I mean, apparently I didn't get a chance to read. Apparently the baseball players are having a problem, the MLB, just with all that social distancing. Apparently there's been an outbreak on one of the teams. So, you know, we're going to have to adjust to this until there's a vaccine, I'm afraid. So the more we can be creative about this, the better.
I just wonder, if I could just add, I just wonder though, if, you know, if the parent kind of initiates with us, so I understand that the school would be notified. But is that going to create an issue in terms of what information we share back to the school? Or that I'm just trying to wrap my head around that.
Now, they'd still have to consent. The parent would have to consent, obviously. And then, now there could be a dilemma. Parent says, well, I live in the school district where T-Chat's there, but I don't want you to share anything with the school.
That's what I'm wondering.
Initially, when we're at ground zero, I'd probably say, oh, I just want to utilize my resources and help people. That's what I go start out. Long-term, that's an issue. There are a bunch of people who are having no contact with the school at all. But I think we have to cross that bridge when we come to it. At a certain point, you might say, well, no, this is a partnership with the school. We really work about it. And we'd be encouraging all along the way. What are your fears about the school knowing? No, it could be really helpful.
I would feel more comfortable if we stress that it's a partnership with the school.
We would, but I wouldn't say no up front on the phone. That's the thing. Well, particularly if I have people sitting that aren't seeing anybody.
Yes, and Michael, our consent forms specifically state that the data sharing and the information between the school and the parent is what they're also consenting to.
Perfect.
And Shannon, you were trying to get back in.
So I think, again, we need to be agile and understand the situation that our kids are going to be facing in the fall. That being said, because the way it was created in statute and through Rider, it is a program that's run through the school. If we want to change the nature much more than that, we're going to need to go back and talk, I think, to the legislature to figure out the best scenario. But I also think Dr. Wakefield, the way that she described it was, if a child, if you understand that that child attends a school within your region, then let the child work with the school to start that process. Otherwise, I think that we can talk through other scenarios. I just think if it gets too far away from the original intent, we need to go back and just clear this with the folks that wrote the bill and the writer.
Okay. Dr. Newland, it looks like you were trying to get in.
I guess I have some comments and then some questions. So some of the thoughts that I've had are, I know there are a lot of hotlines that are run by our mental health centers, for example, that are actually getting a lot of calls. People aren't afraid to call. They're just a little bit more wary about coming in person. And is that one way to kind of help engage young people who need help, but who aren't present in schools just yet? Because they're already a partner on CPW. Another thought was also working as a way to kind of engage our primary care providers through T-Chat. In other words, we have primary care providers who don't have embedded mental health services, but maybe we start them out with T-Chat and then they'll take over their care because we've already kind of worked with them by providing a service, getting the kids started in care. Now they just need to take over their care. Maybe they'd be more willing to engage on CPAN with that level of support. But all the while, like you've already described, have the ROI in place for the school counselor so that when they go back to school, the school counselor is in the loop and knows what's going on in case the kid has a crisis at school or needs more support when they get back to school. And then lastly, there are school associated service providers like private or nonprofit providers who probably could use this support that would be natural partners, but who aren't already a partner with the consortium. The question that I have is, do we have to have an MOU with the ISDs where the kids attend? Or can this be for any kid in the counties that you're covering, say under CPAN, or the counties served by the LMHA you're working with? Like, how do we regionally decide which population of kids we're working with?
I guess I'll jump in and then somebody can disagree, but I think, again, as much for T-Chat as you can stay within the model of supporting the schools that you have MOUs in place with, and having the children and reaching out to parents, but having them contact the school and looping them in, the more consistent we're going to be with the legislation that was passed. Okay.
It seems that in addition to the consistency with the legislation, that if contact is getting made for a service that's falling under the auspices of T-Chat, and it's not coming from the school, that if the school doesn't get connected in it, that they don't know, that they may well not know that they have a child that they need to be connecting with in a different way as well. So if a call comes in, it seems to get them back into the counselor, making a connection in the way that it would typically be happening, encouraging that family, encouraging whoever it is that's making that contact to go through that channel, helps to kind of close up that what could become a challenging communication loop.
Yeah, and some of the schools are setting up clinics on site. I think some of our kids just don't have Wi-Fi. They may have a device, but they don't have Wi-Fi. So they're willing to have clinics at school, even if they're not having on-campus school.
And this is Brittany Nichols. So we're going to choose to work through the schools, even if the kids are at home, with the assumption that we can educate the school counselors and that they can send information on the TCHAT program to parents. I'm sure that the schools have a way to do that, so that even if the kids aren't in class, they can contact the school counselor and make arrangements to get the kids seen. But I know that we're going to move forward with planning that all of our referrals are coming through the school, even if kids are not physically there.
So Karen Wagner has her hand up, and then we're going to need to move forward in the agenda just because we have other items we need to finish up before 4 o'clock. Dr. Wagner?
Yeah, I just wanted to, let's see, bring up, because we have a couple of different models here, and yes, we want to get patients coming in to TCHAT, and we're going to try and be as flexible as possible. I mean, our program, we have MOUs with the schools, and we're working with the counselors, and some kids are being enrolled. But there really is a different model that was discussed here, which was if parents call, then going to the school, that sounds fine, the school's looped in, but I think we really do need clarity as whether if parents call and there's no looping in with the school, that's a really different model. So, and we're going to need some clarity on whether, to me personally, it's beyond the borders of the project, but I don't want to speak for the project.
I think that goes beyond what TCHAT is, and I think you can refer them in through the TCHAT model we built, or to see their pediatrician. We can support their pediatrician, but this was designed for short-term intervention that the school thought was in trouble. And as much as we can adhere to that, the better we are, I think, going to the legislature.
So we want school involved.
Octavia, I'm gonna let you jump in, but then again, I really think we need to move to the last agenda item.
Thank you, David. It's really a quick question. It's a little bit different. It's about bullet 3, the medication guidelines. It's for Laurel, but might even be a little bit more for Steve Pliska. There's a separate program that's been around for quite a while, the psychotropic medication parameters, that I know Steve has worked a great deal on, Lynn Crispin, myself, and some others. My question really to everyone is, because I think it's CPAN and TCHAT related for the primary care providers, will we be distributing or maybe leveraging those parameters that already exist to be utilized?
Yes, so definitely, we have a couple of teams in different ways that are looking at different algorithms that already exist. I think one of the things that we're discussing though is when it comes to TCHAT, it's a time limited service. So if I start a treatment with a young person as a physician, how do I, in the appropriate way, stop seeing that patient that I've started seeing? So it's not so much about the algorithm of what medicine to pick, but more how do we make sure that we ensure a correct transition from TCHAT that's just short term to another team member, another physician that's going to do that care afterwards.
Thanks for the clarification, Laurel. But I would imagine we are going to make the primary care providers aware of the medication parameters as well.
Yeah, we're linking to that actually in both the ADHD materials and the anxiety materials as part of the plan. Among ourselves, there was some interest maybe in a more accessible, perhaps simplified version for primary care that we had at some level talked about. Maybe we would go over with Molly and or Lynn, but Octavio, point being that the parameters are top of mind for their usefulness in this context, definitely.
Okay. So Laurel, let's finish up this presentation, and then again, I need to switch to the last item.
Work in progress, folks, and we'll keep you updated. The last slide is just about the referral system. We are still looking at different ways to have a more comprehensive database of systems. We're actually looking at a couple of systems, not just one. So as we get more information about that, we will certainly talk with you. The slide you see here is about WellNeti, but we are looking at some other platforms beyond WellNeti. So I'll have more to say at the next meeting.
Okay. All right, well, why don't we go ahead and jump into the last agenda item, item number 6. We're coming up to the end of the fiscal year, and appreciate the feedback, the data that you've given to Michelle and Nagla and Luanne, but want to talk through where we are fiscally coming up on this year and think through together how we can plan out how dollars that are currently not marked for certain services or how we can think through how we can use them. And so, Michelle, you want to guide us in this conversation?
Sure, no problem. I'm going to share my screen. All right. So thank you very much for everybody getting me their budgets. I know that you probably spend a lot more time with people than you do numbers, and I appreciate your patience with me as we start working through this. Just wanted to say that I realize this is a first iteration. I've met with some of you, not with all of you, and I think our intention is to have some one-on-one meetings with each of you to go through your budgets in a little more detail. But based on what I've received so far, we're looking like we will have around $12 million that won't be spent. A lot of that is roll forward funds from year one. We know you've experienced some difficulties with COVID-19 and recruiting and getting people up to speed, so this isn't unexpected. But of that 12 million, currently it looked like 2.5 of that was ongoing operational costs that you identified within the budgets that you weren't expecting to spend in year two. So those are funds that we would expect year on year you would need to move your programs forward. So as we meet with you and start talking through this, we'll just confirm that that is accurate, and that as you move your programs, assuming we get funded for future years, you won't need those funds. But there were some institutions that are keen or at a point where they would like to expand. And so if you truly believe that you don't need those funds, there are other institutions, other HRIs that could make use of it. Looking at the, I guess, 9.8 million that isn't ongoing operational funds, these are funds that we could use for one-off costs. And we need to think about what types of things we could use that for. Mostly it could be technology costs, things like EMR integration. I know, Dr. Vo, you talked about that previously. It could be developing an app that makes the services more functional. It could be marketing. It could be expansion of Project Echo. So I think we need to spend a little bit of time thinking about what our criteria might be and how we want to go about assessing how we're going to use these funds after we go through this process of meeting with each of you to finalize these budgets. So Dr. Plitzka, I know you had an idea about, for example, a TChat app. I know Dell and UTRGV, you had some intentions of potentially expanding services. So you would be interested in applying for an increase in operational costs. And Dr. Lakey, I don't know how we want to move forward in the conversation around the different pieces, but we need to think about how would we rate and how would we prioritize the submissions.
Yeah, so let me jump in real quick, Carol, and then I can let you jump in. And I think Luanne, or Lachelle, that other document that we put together, if we could maybe put it up on the screen. But we are in a situation where, because of the challenge of standing this up in the first place, compounded by COVID and a pandemic and the recruiting challenges, that there are some unspent dollars in year one. Now, as Lachelle noted, there's some cleanup here that needs to take place. She needs to talk to, we need to talk to each one of you and think through what those numbers really look like. But again, we want to be good stewards of these dollars and figure out how we can maximize their use. In the report to the LBB, we said that each institution had some ability to move money around in their budget. We also said that we could move money around as a consortium as a whole, 10%. But if we had to go above that, then we would need to go to the LBB and get their permission to move those dollars in larger amounts around. And so Luanne and I and Nagla and Lachelle put together some thoughts related to some ground rules on how we could approach this. And one of the concerns is if you push all those monies, all those dollars from year one to year two, and you build ongoing programs, that's going to be a challenge for the next legislative session. We're planning on the ask of being 115 million, or basically $57 million per year. If we push too much money from year one to year two for ongoing costs, then you would need more money than that during the next legislative session, which just frankly is not going to happen, right? Under the budgetary challenges we have. And so we need to make sure we don't increase the cost of year two or fiscal year 21. We've also been, gotten pretty clear guidance from the legislature in our conversations. We can't put these clinical dollars into the research pot. And so it needs to be helping with TCHAT, with CPAN and CPWE. If there's smart things that we can do to build those programs without, again, incurring additional costs in the next legislative session. And we put down consideration will be given for efforts that improve the implementation of the budget projects on a statewide basis. Are there some things that if each of the academic centers, say, has $100,000 that would be lapsed, but if we pulled it together, we could do something that would help everybody? It seems like that would be a reasonable potential use, such as marketing technology, Project Echo, the integration into the EMR. There's some smart things like that would be useful for the long-term success of this project. I would like to start collecting those ideas and start thinking through them. And so a draft approach, and Luanne, I don't know if you want to go through this, or I'll kind of read through here, is that first, we need to talk to each of your institutions to really figure out what money really isn't going to be spent, and then have at our next meeting on the 31st, a variety of proposals, and spend a significant amount of time at the next meeting thinking through what those reallocations would look like, and having this group approve those reallocations. And again, if more than 10% of the total amount of our funds are to be reallocated, we'll need to go to the LBB and get their approval. And again, in the current situation, that's going to be a very tough discussion unless we can really show what these dollars are going to do to incur or to help sustain the long-term success of this initiative. So those are our initial thoughts. And again, we hope that we could come into this conversation with all that data, but as we're getting this data, again, this becomes
Lost you, David.
that we need to do some cleanup on the data. There's some data that we haven't received yet, and we need to go through that. But at the next meeting, we're going to need to make those decisions and think through how do we approach that conversation. So Carol, let you jump in.
Dr. Lakey, can I say one thing real quick?
Sure.
This is Luanne, and this is a very high level estimate. Many of you did not incorporate your research initiative expenditures into these numbers. So be advised that that it isn't 100% looking at this number. I mean, that this number is going to move once all of your information gets incorporated. So I just wanted to point that out.
No, very, very good. Again,
preliminary estimate.
This is very preliminary. We're trying to be transparent. We're getting the information from you and sharing it. And to be clear, there's a lot of cleanup that needs to take place.
Yes.
On the other hand, it looks like there's going to be some unused dollars, and we need to think through that process. So I'm going to use the participants function here where you raise your hands but Carol, I started off with you. Carol, what did you want to start off the conversation, and then I'll be going to Steve Strakowski and then Steve Plitzka.
So thanks, David. I'm going to just say that the research groups have already, the networks have already requested that if you additional money really for participant reimbursement. At the present time, each one of the sites has included enough to recruit 200 people into their children into the networks. But you know, we have to really reimburse them for their time. So there are some sites that can recruit more, and we would surely ask for money to allow that recruitment to expand. And then there are some special initiatives, of course, that that you had suggested you would at least keep in mind on a competitive basis that we would absolutely choose to do. I can't really understand why you said that these funds cannot be spent on research. And maybe you want to repeat that so I get it. But I would, that doesn't keep me from asking.
No, I understand that everyone's, people ask, but it was pretty clear to us in our conversations with staff and elected leadership that $10 million was the amount of money that would be allocated for research. And I think if we push that up, that would not be well received by the legislature. For us to underspend in the clinical services and overspend in the research, again, would not be well received. And so I think we need to hold fast to that $10 million cap on the amount of money that would be used in research. Okay.
For the research people that if we underspend within research, we could still take that underspending and roll it back into research, just as long as we don't go over the 10 million.
You can do that, and that's where when UNT Health Science Center thought it wouldn't be able to use some of the dollars, we would roll that back into the research. But the conversations with the legislature was that there was $10 million to promote that collaboration for research. Okay.
I get it. Thank you.
The other issue, Carol, to your point, is that as you recall, the FY20 revenue amounts for the research initiative as part of the amendments included the last 3 months of this current fiscal year.
Yeah.
June 1st through August 31st, obviously, as I spoke earlier, indicated that some of those amendments have not been fully executed. So we could anticipate that some of that research revenue will go unspent in FY20 with an intention of spending that revenue on the expenses that were assumed to have been spent in 20 into 21.
I get it. Thank you very much.
So let me go to Steve Strakowski. I'm having some computer problems, so if I fall off here, I'll log back on. And I know my picture's frozen. But Steve, let me go to you, and then we'll go to Steve Plitzka, and then to Michael.
Okay, yeah, sorry to lose you. I was kind of riff off of Carol's point, and part of this is linguistics that I think we have to be wise about. But what my opinion is, one of the better uses of extra dollars would be to do service delivery projects to investigate which approach to clinical care delivery might be most effective across sites. Now, one might call that research, but one might also call that quality improvement or care delivery improvement. So I would be careful. My only suggestion is, let's not, I can understand why we put this in writing so that we stick by what we said in our 10 million, but using these dollars to run a couple of comparison projects about care delivery, which is research, but is also clinical care delivery, would be, in my opinion, the wisest use of extra dollars rather than just throwing them out there to be taken up however they get taken up. So I understand why the dot's there. I would not allow it to limit how we think creatively about the best investment of extra resources. So that's my opinion.
All right, no, thanks, Steve. Steve Plitzka?
Well, kind of just so thinking it through so I'm clear, when I filled out the spreadsheet, like I had one line within TChat, there was like, I think it was like 250,000. I put ongoing operational costs, no. And so it doesn't add to my budget in subsequent years. And then even after that, there was the 215,000 of unspent funds that you saw in that spreadsheet. And that 215 is what I thought would go in the general pot that you're talking about. Now that 250 that I suggest proposing a special project, do I get approval for that to do a project within San Antonio, or does that 250 get added to the 215 for these more global projects?
And I think
go ahead.
I was just going to say, I think part of the your project that we would want to know a little more about is there a possibility of doing something, an app, for example, that would be useful to all of the HRIs? And so if there's a way to expand it in such a way that everybody can make use of it, we would prefer to do that. And so it's in that instance, we just want to know a little bit more about what you're proposing.
Okay. Well, I guess that's the philosophical question for everybody is whatever we're going to spend the unallocated money on has to be is going to be in one pot decided by the whole group versus there'll be two pots, things we've kept to ourselves, so to speak, versus those that goes into the general pot. I'm asking clarification on that more global issue, because in that sense, it wasn't 215 in unspent funds, it was close to $500,000, because that 250 is going to be added to the 215 in terms of the global project. Or are we saying, yeah, 215 goes to the global project, we'll vote on that. We mark 250 of your funds for you to spend with approval of, say, David, or, it's a process issue, but it's very profound in terms of how we budget the money and how everybody thinks about the unallocated funds.
I think you have the ability within, I think we said 10%, of moving money around in your budget to address needs. If there are, after you do that, if there's dollars that you're not going to be able to spend, then I think that goes to the bigger pot.
Okay, well, because right now my plan is to propose, I guess, to David, you, and what I want to do with that 250. The 215 goes in the big pot and we'll all talk about it. That's how I'm thinking about it right now. I just want to make sure that's the correct way to think about it.
I think that's correct. And again, I would remind people in our LBB report, we said that if there were unspent dollars, that we would try to expand TChat to additional schools and CPAN, that especially TChat, and make it more available. And so I think you have the ability to think creatively of how can you, if there's funds that you, because the way things have stood up, it's harder to do TChat, but now we can do broader within your own budget. Maybe it is an app, maybe it's reach out in other ways. I think those would be high priority items.
Yeah, but
I think there's been other items, and let me bring in Michael.
I'll shut up. Go ahead. Go ahead, Mike.
He had an idea that he presented several months ago related to partnership with the local mental health authorities and other local mental health authorities that were really craving through telemedicine the partnership with his center. I think things like that would be very favorably looked upon. But Mike, why don't you jump in?
Yeah, okay. A couple of things. I just want to second what Dr. Strakowski said, that I do think one of the missed opportunities so far has been analyzing, and I'm not going to use the R word, but analyzing our services utilization and the different factors and outcomes related to that. So I hope we can think about maybe using some funds to look at that in more detail. But the two things one main thing I just wanted to bring up, I didn't understand the philosophy behind not increasing the operating cost in the next year. I understand that, once their operating costs, that could be thought of as carried over into the next biennium. But if we had a 1 year increase in operating costs so that we could reach more people and then cut back after that, what's wrong with that possibility?
So I think as long as you can, the trap we can't fall into is that you build in a service and then are reliant upon the legislature to put more money in, or you're going to have to cut that service, right? That the legislature never wants to get put into that trap. And so if there's dollars that you could use within your budget to enhance those services next year through marketing, through Project Echo, through a variety of things that are going to build that service, but your operating costs come up, but then will come back down to that other steady state so that we have the same amount that we're going to be asking to the legislature. I think that's going to be fine. What I can't do is build it where you're going to need sustainable additional dollars that aren't in your budget. Does that make sense?
Yes, but let me throw out a specific example. What if you were able to, see more kids because you hired a half-time person to take some of those calls? So that would, bump up your operational costs, and then we wouldn't want to keep that going forward. Is that what you're trying to avoid, because it would reduce services after that year?
Yeah, you need to expect that those dollars won't be in your budget in year 3.
But you could still do that if you assume that.
If you
If you propose like a short-term increase.
If it's a short-term increase because you think there's a surge and you can justify that, but you have to be ready that those dollars will not be in your budget. And don't be in a position where a service now is yanked out from under somebody because of that issue. Okay.
And if you have the extra funds, you can add those line items in and just put no under operating cost, and you can designate that it's a contract staff or it's something that designated it's for a short term.
Okay.
But Michael, if you see that there's some additional costs that you need next year in order to get this up and going, then I think that would be
that's the easiest.
Yeah. Okay.
Yep. Personnel expenditures generally are not considered as one-time expenditures. So if you wanted to sustain a position over time, you would not be able to do that because you have to assume no increase in budget for FY22. So if your institution could pick up the cost for that position that you created using consortium revenue for FY22, that would be a whole different thing. But oftentimes it's difficult to hire a staff position knowing that position will end, or at least the funding for the position is not sustainable past August 31st of 2021.
Okay. All right. Alex Vo.
I just want to follow up on the previous meeting that we had. I believe there was a letter that UT System or the consortium administrator was going to send to help us with our finance folks. Did that take place, in terms of rolling over the funds to be used in FY21, as well as, now that we have this additional conversation, can we update that letter if that has not been done yet, to include some of this flexibility of the use of funds for up to 10%? That would be really helpful for our administrative folks who need to have that kind of reassurance that we can do that.
No, Alex, I think it's a good point. As I was looking at the notes, it's very clear that we were going to put a letter together. That letter has not gone out. I will work with our folks to make sure that we pull all this information in a letter that goes out to folks. So that's on us that we haven't gotten out, but we will adjust that with this additional input. Okay.
Can I make a clarification on that?
Yeah.
Dr. Vo, my understanding was that you needed the clarification specifically regarding the unspent revenue in 2020 into the 21 budget that would come from the Texas Higher Education Coordinating Board. Similar to the information that was provided, I know we sent it to UTMB earlier in the year. It sounds like that you just need that to be reiterated. Is that correct?
Yes, and if there's
Okay.
additional guidance based on this current conversation that, we are allowed to be judicious about a 10%, be flexible with 10% of the funds that we receive, that would be really helpful too.
Okay, yeah, because we'll just take language from the participating institution agreements, because that language is in the agreements. And then we'll pull the language from the LBB report as well, and then get the information from the Texas Higher Education Coordinating Board.
Thanks so much.
Uh-huh.
Dr. Wakefield.
So when I was just wondering if you guys were going to give us a framework of the, and sorry, I was taking a call real fast, so I might have missed this information, but I saw the outline. And should we just come up with a proposal, or are you going to send a framework for us to do that?
We can send a framework. Again, I think that the first step is for Lachelle to talk to everyone about the budgets they sent in, and we can send this framework out. But at the next meeting, I think we need to have that list of after you do things internally, how much money is really available to think through as a group, and what are some of those priority things that the group would like to do. Or if your institution, even when you're spending all your dollars, there's additional opportunities to do more, expand, teach at, et cetera. What are those opportunities? And we'll need to think through how those dollars could be.
Well, and maybe this is a better question for Lachelle, but I included justification for all of our proposals on that document when we sent it back, with associated costs and value to expanding the programs. And so if we need information beyond that, I'm happy to give it, but I would have to have some direction on what additional information beyond what I've provided is needed.
Yeah, and we'll review that. I hadn't had a chance to go through that in any detail, but I'll review that. And if there's any gaps, I'll reach out.
All right, thank you.
Mm-hmm.
And the reason Lachelle hasn't had time to do it is because, I think on Friday we had 4 of them, and then she got another handful over the weekend. And so really has not had any work days since she received these. And so needs to dive into these. And again, that's where this cleanup needs to take place. Okay. All right. Any other comments? Okay. So along, following up on this conversation, at our next meeting, one of the things that we're going to do is bring in a presentation from the folks from Massachusetts who leverage CPAN to address maternal depression. They basically use this type of platform and then expanded to address the needs of young moms. And I think that's something that we should continue to think through. And we have that presentation, next week. Are there ways that we could leverage this infrastructure and with a few tweaks, be able to provide a really essential service? That strategy was put into HHSC's strategic plan for postpartum depression. I think this is what Carol was alluding to earlier about, any idea that I have. I think there might be some ways to be able to address another critical need from the state with just thinking a little differently with some of the funds within the legislative intent. One of the pieces of information that would be useful to us as we think through that, I don't have a good feeling about how many perinatal psychiatrists are in the state of Texas. And so I think we'll send out some, a survey and try to get that information. I see Laurel, doing this right now. We'll try to get that information, and I think we'll have a good conversation. Again, I'm trying to be very transparent of why that presentation is occurring. But if there are unspent dollars and there's an opportunity that's consistent with the state plan and could be consistent with state legislative intent, there may be ways that we can add some additional, hopefully wins to what we're trying to do here in Texas. Octavio, I see your hands up.
Thanks, David. Just trying to, great suggestions already from everyone, including yours, but just to think out of the box, if there's any of these dollars that could be utilized to address more of the bigger picture, not so much healthcare that our kiddos need, but health, social determinants of health, something that could be across the board. I don't have any specific ideas. It's just really more of a concept, especially our families that are, from communities of color that are getting hit so hard through COVID-19. And we've seen the statistics, increased hospitalizations, as well as increased mortality rate. And just another second thought, could a portion of it all be used to create a strategic plan for sustainability of the program into the future, not just look at the immediate, next year or even the next budgetary cycle of the legislation, but coming up with something strategic that is here's a sustainability plan for the next 10 or 15 years that we could move toward and work toward. Just a couple of thoughts.
No, I appreciate that. And I welcome all thoughts. I will say that I think we're going to have to all be very careful that we follow the legislative intent of the dollars as closely as we can. That if there's any perception that we're being loose and getting outside of what that legislative intent is in the midst of everything else that's going on in the state of Texas, it may not help us in our long-term success. None of us want dollars to lapse. However, if it looks like we're being loose with dollars, that may play out to our detriment as we try to get the $115 million next legislative session. So I want us to look through all of this through that long-term lens of how do we make sure that the long-term success of these projects. Okay. Any other comments?
This is Luanne, and just want to reiterate, Dr. Lakey had mentioned some of the things that could benefit everyone. I know we've had some conversations at consortium meetings in the past about some of the technology expenditures that may have been unanticipated prior to actually delving in with COSH implementation and those kinds of things. I know, Dr. Vo, you have spoke very eloquently in the past about EMR integration. And just as Dr. Lakey's talking about the future and thinking about building the foundation we need to be able to sustain an infrastructure to do telehealth through a TCHAT model and a CPAN model across the state of Texas for the long haul. Those would be things I know that many of you have brought up that, may be things that you want to think about, that you may not have put into your HRI's budgets, just because, when you start something from scratch, there's just some unanticipated things that may not have been thought through at the beginning. So I just wanted to reiterate that.
Okay. All right. Any other comments for the good of the group? Hearing none, we have 4 minutes before the hour, so we are done on time. Thank you all for your time this afternoon, and we will be meeting again in the end of August. Thanks.
Thanks,
Thank you.
David.
Thank you
Bye-bye.
all.
Thank you.
Thanks,
Bye-bye.
guys. Bye.